temporal sclerosis, especially for neurosurgeons, is a big challenge, because as neurosurgeons we are used to identifying only big tumors. So MTS, even though it's one of the commonest pathologies for epilepsy, but it is still a very subtle pathology from the neurosurgeon's perspective. So he will briefly tell us how it is done, and this will be followed by case discussion, where we will discuss today's cases. We have posted 3 cases, 2 MTS, both for laser, and 1 MTS for open. And after case discussion, this will be followed by Professor Ashwini Sharan on a presentation on the laser technique, which we are going to do for 2 cases today, and that will be followed by my case, where I will demonstrate how to do the surgery for mesial temporal sclerosis. So till the lectures are going on, we will keep the OTs, patients are getting induced, and we will show what is going on. So Ajay, please come in.
Thank you, Dr. Sharath. I request all of you to come in the front row. So, yeah, it will be easy to see. I will be using pointer. Can I have the lights off? This area. Just. Okay. First of all, I will be talking about the anatomy of the temporal lobe. As we all know, the temporal lobe can be divided into 5 gyri. First of this, we have the Sylvian fissure, which separates temporal lobe from the inferior frontal gyrus. Then we have the superior temporal sulcus, first temporal sulcus, then middle temporal sulcus, then there is a third temporal sulcus, and then we have the collateral fissure. This is the white matter band which separates the collateral sulcus from hippocampus. This is the collateral white matter. So we have 5 sulcus, or these are the gyrus. We have the superior temporal gyrus between the Sylvian fissure and the superior temporal sulcus. Then we have middle temporal gyrus, then inferior temporal gyrus, then we have the collateral, the fusiform gyrus, and the parahippocampal gyrus. So these are 5 gyrus in the temporal lobe. The anatomy of the temporal lobe is best seen in coronal images. So we should always try to look at the coronal images first. Then if you look at the hippocampus, it protrudes into the medial region along the floor of the lateral ventricle. It is a C-hook shape, so we call it hippocampus. It has been divided into 3 parts. We have the head of the hippocampus, followed by body and the tail. The head, if we look at the head of the hippocampus, it is the only part of the hippocampus which is not covered by choroid plexus. It is oriented transversely. We have the various bumps over the superior surface of the hippocampal head. So these are the digitations. In early cases of mesial temporal sclerosis, these bumps are lost. Then we have the body of the hippocampus, which is more cylindrical in location. It is divided into the different regions. We have the dentate gyrus. Then we have the Ammon's horns, which surrounds the dentate gyrus, which is continuous as subiculum and parahippocampal gyrus. Then there is a fimbria, which is over the surface of the body of hippocampus. And then we have on the lateral side, we have the trigone. In cases of the mesial temporal sclerosis, we look at the signal intensity of this hippocampus. We look at the size of this collateral trigone. We look at the size of the collateral white matter and other features. So in the hippocampal formation, we have dentate gyrus, then Ammon's horns, which is continuous as subiculum. The dentate gyrus is composed of the granulal cells, while subiculum and Ammon's horn, they are composed of pyramidal cells. Both are excitatory neurotransmitters. The dentate gyrus cannot be separated from CA4 regions of the Ammon's horn. On imaging, you can't differentiate these 2 regions. Then the CA1, CA2, they are depending on the histological difference in the cell bodies. There is no well-defined imaging borders to differentiate these regions. And there is a gradual transition. Then some of the regions, they are more susceptible, like CA1 is most commonly involved in the mesial hippocampal sclerosis, followed by CA4. CA3 and 2 they are relatively resistant to MTS. Then we have this black white matter band, which separates the dentate gyrus from Ammon's horn. This is called as zona granulosa, stratum radiata. This you should try to see on imaging. In cases of mesial temporal sclerosis, this hypo-intense band on T2 weighted images is lost. Then we have the parahippocampal gyrus, which is over the medial aspect of the temporal lobe. which is continuous anteriorly as uncus. Posteriorly, it is divided by calcarine fissure into isthmus and lingual gyrus. Isthmus continues with the cingulate gyrus, and lingual gyrus continues in the occipital lobe. Then there are two important structures in the parahippocampal gyrus. One is subiculum, which is continuous with CA1 region of the hippocampus, and second is entorhinal cortex, which is over the medial surface. Sometime in the mesial temporal sclerosis, only the entorhinal cortex will show increased signal intensity. So we should always look at the signal intensity in this region also. Then entorhinal cortex is the main interface between the hippocampus and neocortical structures. On the axial section, the anterior aspect of the hippocampus turns posteriorly and medially, which is known as uncus. There are two regions of the uncus. The posterior region continuous with the hippocampus, and the antemost region have two protuberance, which is semineural gyrus and the gyrus ambiens, which are seen on the medial surface on coronal images. Then we have the amygdala, which is an oval shaped structure, which is a gray matter structure, lies in the depth of the uncus. And this is the uncinate gyrus which connects. This is the uncinate gyrus which connects the amygdala with the medial hippocampal structures. So the imaging is done in cases of epilepsy to look for the epileptogenic substrate. We do functional MRI and diffusion tensor imaging to look for the relationship of this substrate with the brain regions. Then post-op, we look for imaging is done for to look for the resection, look for the region of operative failures and complications. The MRI is the imaging modality of choice, and we do imaging. If we do imaging, around 20 up to 20% of the cases will be MR negative. It is very essential to find out the cause of epilepsy in such patient because the surgical outcome is better. In patient where the MR is normal, the surgical outcome is 41%, which increases to 71% when MR is positive. So we should make every effort to find out the epileptogenic substrate on imaging. This is the imaging protocol we follow. We do axial, T1, especially we do 3D sequences in 3 planes. 3D T1, 3D flare, and 3D DIR optionals. We do T2 relaxometry in patients where you are suspecting mesial temporal sclerosis and the conventional MR is normal. Sometimes we do spectroscopy where you are suspecting MTS, the rest of the imaging findings are normal. So, and then we do coronal T2 flare, coronal T2, and coronal IR sequences. Whenever you look at, you want to see the MTS, always look for the symmetry of the images. The images should be symmetrical so that you can compare one side from the other side. For symmetry, we always look at the internal auditory canal. On the internal auditory canal should be seen on both sides in the same slice. This means the images are symmetrical. And then you compare the intensity from one side to other side. The hippocampal is a old cortical structure. We should compare the signal intensity of the hippocampus with the insula. Whether it is more bright than insula or less. Sometimes the MTS is seen on both sides. You can't compare one side from the other side. So always look at the insula or cingulate gyrus. And then we do MPR sequences. We can recon images in different planes. This is helpful for pick up focal cortical dysplasia. And then we can do convener reconstruction. Here you can see the this is cortical dysplasia on one side, polymicrogyria, which is well seen on this reconstructed images. And then with 3D images, you can recon in different planes, look at the intensity. This is helpful for pick up dysplasia and MTS. Now coming to the imaging findings of the MTS. There are two main characters of the MTS. First, there is the increased signal intensity of the hippocampus on T2 and flare sequences. Second, there is a loss of volume. Both should be present to make a diagnosis of mesial temporal sclerosis. Sometime in patient with epilepsy, you can have increased signal intensity on T2 and flare without any loss of volume. This could be effect of the seizure itself. So both should be present to make a diagnosis. Here in this case, if you see, on the left side, the hippocampal looks brighter compared to the contralateral side. There is an increased loss. There is a loss of volume. Look at the size of this temporal horn, which is dilated on one side. So this is the case of mesial temporal sclerosis. Then if you do PET scan, sometime in PET scan you will see hypometabolism in these cases. Now we are started doing arterial spin labeling perfusion images, which also shows the decreased perfusion in such areas. Then we can have these secondary findings, like you can have the atrophy of the fornix on one side, on the side of the MTS. You can have atrophy of the mammillary body on the side of the mesial temporal sclerosis. or sometimes you can have atrophy of the same side of the temporal lobe, or maybe the whole of the hemisphere is showing loss of volume. Sometimes we can have the diffuse unilateral hippocampal sclerosis where the head, body and tail of the hippocampus is involved. Sometimes only the head of the hippocampus is involved, or sometimes you see the bilateral mesial temporal sclerosis where both of the hippocampus shows increasing intensity and loss of volume. This is the example we can see. There is a MTS on right side. There is increasing intensity on T2 weighted images, flare sequence. These are the inversion and recovery sequence. Look at the thickness of the collateral white matter. This is the collateral white matter on the normal side. On this side, the collateral white matter thickness is less. Look at the size of the temporal horn. The temporal horn is wider on the right side compared to the left side. So these are the subtle findings you should look for in cases of the mesotemporal sclerosis. Then we can have the bilateral mesotemporal sclerosis where the both sides of the hippocampus shows loss of volume and increasing in intensity. Then if the MR is normal, we can do T2 relaxometry, which can differentiate, which can show the increased relaxation time in areas where there's a mesotemporal sclerosis there. Then sometimes spectro can show the decreased Na and choline. This is not very helpful in differentiating, but it can, if the spectro is showing Na choline ratio is less than 0.8, or your SPECT and other findings are also matching, then you can take it as a positive. Then in 15 to 20% of the cases we can have dual pathology. This is an example of cortical encephalomalacia with mesial temporal sclerosis on the same side. In this example, this patient was having parental insult. We can have gliosis, loss of volume in both occipital lobe. In addition, there is a mesial temporal sclerosis on the right side. The right side hippocampus is brighter, loss of volume. The temporal horn is dilated. These are only 3 findings you should look for. Now, this is an example of cortical dysplasia polymicrogyria on right side with MTS. Sometimes changes can be seen on other side. In this example, there is a cortical dysplasia in the right hemisphere, or there is a MTS on the left side. So you can have the contralateral pathology also in cases of dual pathology. Then in cases of the mesial temporal sclerosis, always try to look at the signal intensity of the gray and white matter in the temporal lobe. In this example, if you look at the signal intensity, here on the right side, we can see well differentiate the cortical margin and the gray matter. Gray matter and white matter is well seen. Here the white matter is slightly bright in signal intensity. This is an example of type 1 cortical dysplasia associated with MTS. Sometimes it may be helpful in pick up the MTS. So always try to look at the white matter differentiation, gray white matter differentiation in the temporal lobe, in the coronal images. In cases of temporal lobe epilepsy, sometimes you can have the enlargement of the amygdala and uncus without any loss of volume. Most of these cases are because of the low-grade glioma or maybe because of the focal cortical dysplasia. Then you should be careful. In this here, the amygdala is larger in size with increased signal intensity. So this is one of the other example of temporal lobe, the dysplasia presenting with temporal lobe epilepsy. Then there may be some variation in the temporal lobe shape. You should be careful. There may be hippocampal malrotation where the hippocampal height is more, width is less. So these cases should not be diagnosed as MTS. So one should be careful in looking at these cases. The hippocampal height will be more, the transverse diameter will be less. Thank you. Any questions?
Thank you very much, Ajay. So Ajay is a very intimate part of our epilepsy, indispensable part of our epilepsy surgery team. So without his radiological skills, we just cannot take any decisions, and I really thank him for coming and contributing to this conference. Now I will request today's cases to be discussed.
Any questions for Ajay? People will be able to identify MTS now? At least you will be able to tell your radiologist what kind of epilepsy protocol MRI you want. Please do not try to look for MTS on a routine MRI. You understood what epilepsy protocol MRI is? Wherever you are practiced, you should be able to tell your radiologist to do epilepsy protocol MRI. If not, you can catch him. He's still not left.
Do 3D MR, use 3D system.
I would need a sound cable here. I would request my epilepsy fellows, Dr. Reema and Dr. Bhargavi, to come up for the presentation. it is very essential that before we even think of operating a patient, we must make sure that the patient has refractory epilepsy. So you don't operate on patients who are not refractory for the simple reason that hand mic hai? We don't operate on patients who are not refractory for the simple reason is that surgery by itself, unless done in the hands of surgeons who are experienced or who've had had a good learning curve, could have certain side effects associated with it, plus neuropsychological implications. So you have to make sure that the person is drug refractory. So does a neurosurgeon here know what a drug refractory epilepsy is for the residents? What is drug refractory epilepsy? It's copying? Drug refractory, how will you identify that this patient with seizures is drug refractory? So according to the latest definition, 2010, International League Against Epilepsy, a person is defined as drug refractory if he has failed 2 or more adequately and appropriately chosen anticonvulsants for that particular epilepsy syndrome and is not responding to them. So it has to be an adequate dose, the person has to be compliant and should have been taking the drugs, and of course they should be appropriately chosen. For example, a patient with juvenile myoclonic epilepsy, if the neurologist or some physician is giving carbamazepine, will continue having seizures, and then somebody will put phenytoin and still continue having seizures. But that's not a pre-surgical refractory epilepsy because that's a wrong drug for a wrong syndrome. So you must have a neurology colleague who is able to identify the true refractory epilepsy and rule out pseudo-refractory epilepsy. So the first step is to rule out pseudo-refractory epilepsy and identify that this is truly refractory epilepsy. Once you've established that it's truly refractory epilepsy, that is the patient is failed 2 drugs, then you go ahead with trying to identify if this patient has a substrate, because having a substrate is the greatest chance, especially for the beginners. If you have a substrate on your MRI, that's the greatest chance that if you prove that the seizures are coming from there, there is going to be a success. As a beginner, you don't want to start out on MRI negative cases or MRI normal cases. You would want to look for a substrate on your MRI. So you must have a radiologist, you must team up with a radiologist who's interested in looking at a epilepsy protocol MRI, which is different from the routine in that it follows the long axis of the hippocampus. It is parallel and perpendicular to the long axis of the hippocampus, not the orbitomeatal line. Is that clear? And they are very thin sections. Ideally, you should have a 1 millimeter. Some centers do 3 millimeter and 3 Tesla MRI. Once you've got a good MRI done and you saw something like MTS, which we are going to show in the 3 cases today, then you would like to prove that the seizures are coming from that area. Okay? The second thing is you would also like to rule out that this patient does not have pseudo seizures. 9 to 15% of your patients with drug refractory epilepsy will actually have, along with the true seizures, may have pseudo seizures. So that is the role of the neurologist. The neurologist has to prove that the seizures are coming from the same area so that you can confidently remove it or ablate it. And the second is the neurologist also has to prove that the patient does not have coexisting pseudo seizures. Because as I said, 9 to 15% is a huge amount. In our own series, it's about 15%. And if the patient has pseudo seizures, along with the true seizures, and we do not counsel them, and we do not tell them that these seizures are different, they're coming from your mind, and they are easier to control, and these ones require surgery. We don't tell the family and the patient that this is a pseudo seizure, this is a true seizure. We don't counsel the patient. We don't handle the pseudo seizures. After surgery, the person will may keep having the pseudo seizures. And then you're going to think that it is a failed surgery. So that is why you must have a neurological evaluation. You must have a video EEG. Though neurologists can often be a rate limiting step in the process of epilepsy surgery, in that sometimes you will have watertight neurology associations where they may not be willing to hand over cases for surgery, unfortunately, in our setting. Hence, you have to liaison with a neurologist. You have to find a team of neuroradiologists, neurologists, and of course, an epilepsy surgeon. Apart from that, in your team, you must have a neuropsychologist. The role of the neuropsychologist is that In dominant hemisphere lesions as well as in liquid cortex lesions, the neuropsychologist must elicit that the affected hemisphere is affected and the unaffected hemisphere supports some amount of function. So if it's a dominant left temporal, the right hemisphere must support some amount of memory, must support, otherwise if you're going to remove it, the patient is going to be left with significant neuropsychological impact. And that's the beauty of minimally invasive procedures which will be done today. The laser ablation does not impact the neuropsychology as much as would the other procedures. So as I said, we go ahead with the case presentations. And the first case will be presented by Dr. Bhargavi, and we will then discuss the video and the EEG so that the neurosurgeons are also familiar with the terms which we use, and then go to the second and the third case.
Good morning. The first case is Chaitali Ashok. She's a 24-year-old right-handed lady with a normal birth and developmental history. Her seizure onset was at age 5, and for the last 19 years she had been having seizures at about 3 to 4 per month. She has an aura of an epigastric rising sensation, and followed by there is unresponsiveness and oral and automatisms with both hands, with there is some dystonic posturing of the left hand. She has been on carbamazepine 600 milligram per day and clobazam 20 milligram per day. So her clinical diagnosis is drug refractory mesial temporal lobe epilepsy, which is probably on the right side. It's not happening. No. This is stuck, I think. Stuck? No.
So why did you think of the right side, Dr. Bhargavi, in the clinical history? Was there anything to suggest the right side?
There was dystonic posturing of the left hand. That was the reason why we lateralized it to the right.
Hypothesis before we put the patient in the EMUs that probably because of the dystonia of the left hand, we have the seizures arising from the right. That was the only lateralizing feature we got in history.
Then a video EEG was conducted, monitoring was conducted, in which 5 events were recorded in all, and all were suggestive of an ictal. We will see the video first.
So any of one of you is welcome to describe the event if you want. Here she is resting so you can see something is already started. And I don't have a sound cable as yet. I am requesting a sound cable. The technician is trying to test her out. That's Manita technician. And he's talking to her. She's just looking at him. She's not responding. Her left hand, you can see the left hand kind of twisted under the bed sheet. By now the technician should have removed the bed sheet. Now he does it now. But the hand has gone back. It's no more twisted. It's gone back to, but you can still see the left hand. Sorry, this was the left hand. The left hand has some kind of movements. So the left hand twisted and then has some kind of movements. And she kind of purses her lips, and then she kind of looks to the left. So you can see her head and eyes going to the left. Sound cable. The technician is continuously asking her questions, which she is not responding to. So she started with some twisting rotation of the left hand and unresponsive. Has this persistent head deviation. Now head deviation can be early, can be middle and late. So if it's an early just looking phenomenon, not a forced deviation, then it's ipsilateral. But if it is a little later and if it is forced, that is the head is persistently deviated with the sternocleidomastoid standing out, Then the localization is contralateral, and you can see her left hand has again gone into that posturing with a pointing index finger. And then she's kind of okay. The technician is kind of anticipating that she may generalize because she has a history of generalization, though later on in the seizure, so he's kind of taking all precautions and putting a mask. At the same time, he's asking her questions. In the beginning, if we had sound, he would have heard he's asking her to memorize some words. But she does not generalize. And she's responding now. So you can see she's answering. She starts answering questions. She's nodding her head to his questions. नहीं आ रहा? हाँ, दे दो. फुल है. क्या हुआ? For some reason the sound is still not there with us, though I had requested it. And we carry on the video, hoping the sound will appear sometime. And so now it's almost towards starting from the beginning. So instead of showing this, then we go to the next seizure. So we go to the next seizure. Here she is sitting. So as we said, we documented 5 seizures. As you can see here, she indicates to the brother that something is happening, and then again the left hand kind of clutches her dress. So the left hand clutches her dress and gets fisted. It's not truly dystonic, but it's kind of postured. So this is what we call a hand posture. And she is trying to answer things. She's worn the head box, so the technician is trying to get the head box off. The hand is still postured. So now the posturing is kind of gone, and she's trying to pull at things, semi-automatic behavior. And she is kind of responding and answering. She's able to answer the color, she's able to read. He's giving her 2 things to remember. So you can see these episodes are pretty prolonged. So this is the hallmark of this. Actually, it goes on for quite some time. She does respond to the questions. She does identify objects. And this is the hallmark of what we say as mesial temporal seizures. It's a prolonged seizure. So most of the mesial temporal lobe seizures will be very prolonged. It will go on for minutes, 5 to 10 minutes. The patient will not generalize fast. So there is a slow generalization, or later, if the patient is on medicines, there will be generalization. There's a behavioral arrest. There's usually an aura, behavioral arrest, and automatisms. So there is behavioral arrest, aura, and automatisms in a mesial temporal lobe seizure. And along with this, unilateral posturing, which lateralizes to the contralateral side. So unilateral left will lateralize to the left will lateralize to the right. And why does this posturing or dystonia take place? Dr. Reema?
There are SPECT studies, functional studies, which have been shown that there is spread to the basal ganglia in cases of mesial temporal epilepsy, because of which there is dystonic posturing. And they say contralateral dystonic posturing and ipsilateral automatisms have 100% lateralization for the same side.
So if you find a patient who has a dystonic posturing and automatisms, left dystonic posturing and automatisms of the right upper limb, it is 100%, with 100% certainty you can say this dystonia is a contralateral phenomenon. So that's how accurate it can be on your video EG. And for a mesial temporal lobe sclerosis, we try to document at least 3 seizures. In this patient, she happened to have 5 because she was still connected before we disconnected her. But you should document in a unilateral mesial temporal sclerosis 3 concordant seizures coming from that side,
Sometimes the patients don't have seizures and we end up having only 1. Sometimes we have 5, but minimum 3 would be a good. So here we have the ictal EEG. Dr. Bhargavi.
The ictal EEG, we can see that actually this is just before the seizure starts, and we see there are some spikes which are there, which are
You can
not
see the blue here is the right.
side, and the red is the left, and blues the temporal, the F8 and T4, which are anterior and middle temporal leads.
So this is an average montage. So all the electrodes are kind of averaged out against each other. And so this is an average montage, and the identification criteria here will be by amplitude, okay? And of course the side.
So we are seeing some spikes in the on the right side, the anterior temporal and the middle temporal leads are there, which are showing spikes initially single, and then they come repeatedly.
Coming here, and then they kind of increase, and they tend to become rhythmic, as compared to the red, which is the left. Is everybody able to see them on their screens? Yes, no? Okay. And
Then it evolves, and there is a rhythmic slow delta waves on the right side only. Whole of the temporal, all of the temporal leads are showing a rhythmic discharge which has evolved.
posterior is spared, the O2 average is spared, and you're seeing the maximum at F8 and T4. The max amplitudes at F8 and T4, and rhythmic delta. And then it evolves.
And into sharp activity, which is probably in theta range, and it is now quite spiky actually towards
Sharp.
the end.
So that's the evolution of the seizure, and it evolves further, and then
Then
slows
it
down,
subsides slowly.
and then kind of subsides. But you can see post-ictally also, when she is subsiding, there is more slowing and higher amplitude slowing on the right side in the temporal region. So this is pretty certain. And interictally, she has these rhythmic discharges which are coming from T4, T6, and she has interictal spikes with highest amplitude at F8. So the average interictal spikes with highest amplitude at F8. So if you find this kind of picture, you can be more or less certain that these seizures are coming from the anterior mesial temporal lobe. It's very difficult to capture events from the mesial. What we try to see is the spikes at F8 and T2 and T4. So if you find a spike at F8, T2 and T4, T4 of course becomes the middle, but F8 can be posterior frontal or anterior temporal, and T2 is anterior temporal. So you are more or less certain. So if your neurologist tells you this is the pattern, then you can be certain that it's the mesial temporal lobe. So what do we expect in her MRI?
So just a naive comment. Okay, the even numbers are on the right side. T2 means
The EEG terminology is all even is right and all uneven is the left. And F, yes.
In your EEG of the first page, the spikes which are showing, are they not seen on the other side also?
This?
Yeah.
Where are you seeing it here?
Both sides.
See this, we have kind of reduced the filter, but this is the muscle which she was having along with the seizure. These are not spikes. So to show the spikes clearly, normally we keep the high frequency filter as around 50 and 60. But when we want to show in teaching sessions, we reduce the high frequency filter. So the so-called muscle may also appear like this. When the patient has a seizure, there's a lot of muscle which comes in. So we do reduce the high frequency filter to filter out the muscle.
Plus there are blink artifacts.
These are all blink. These are all blinks. So this is another hallmark of a seizure starting. Very often a focal dyscognitive seizure or a seizure coming from the temporal lobe will start with very frequent blinking of the eyes and automatisms. So you catch these blinks on the, these are not spikes. These are the frontal eye artifacts, eye movement, eye blink artifacts. Okay. So this is just to show you the second seizure. She had another seizure which we have done, and you can see the same rhythmic delta which is coming at T4, T6, and then it evolves further, and it evolves further. So there is in fact a rhythm known to this, ictal onset 3 to 5 hertz, evolving to 9 hertz is known as the Reisinger rhythm. And this is very fairly typically characteristic of a right mesial temporal sclerosis. So since we have the radiology lecture, can any one of you identify the findings of this MRI for this patient? Any one of you would want to take the mic? This is a workshop. It is meant to be interactive. And please learn to vocalize your thoughts about the whole thing. Who would want to volunteer? Who's your...
There appears to be a dilation of the temporal horn on the right side, and
So this is the widening of the temporal horn. But is that the most important sign?
and
So first of all, we should try to think what sequence this is. You're a neurosurgeon.
this is
So
a T2 coronal MRI.
Is it T2 or something else?
T2.
So you say there's widening. Anything else you're seeing?
Loss of
So you can see this on the opposite side, on the left side, there is a good volume of the hippocampus, and here there is a loss of that volume of the hippocampus. So volume of the hippocampus is definitely
less on the right side.
smaller on the
Right side.
Atrophy of all the gyri,
Now atrophy.
of all the temporal gyri.
So the whole temporal lobe appears a bit
Atrophic.
or smaller in size than the left. Of course, we haven't done the volume on this, but then by gross visual inspection, it does appear smaller on the right. Anything else? Yeah. So this is not the ideal section to identify the PES, but the PES hippocampi is a undulation of the superior surface of the hippocampus, which gives it like a paw-like appearance, and that can be seen. Some indentations can be seen here. Those indentations are
You're saying
lost there.
fornix being smaller on the,
Yes, very good. So you can see this fornix
and the memory
over
body
here
of slightly
is very thick with a different intensity, whereas here it is very good. This is one of the indirect signs. The fornix is smaller and atrophied relatively on the right side.
memory body of school.
Yes, very good. So mammillary body here is much bigger, and they, you could be biased, but it tends to be a little smaller. I'm not sure, but it does tend. So these are all the findings that you should try to. Next slide. So you should try to identify on the MRI, and this is of course, here again you see the same thing with the hyperintensity which is seen in the hippocampus over here, amygdala is here. So pretty straightforward, and there is some atrophy of this. What gyrus is this? How would you identify this gyrus? Neurosurgeons should be better than me in identifying that. What gyrus is this? Parahippocampal gyrus is atrophied over here. Next. Again here, so the same thing, which sequence is this? Yeah, so again the same thing, you can see even the intensity of the hippocampus, the iso intense over here and it's hypo over here, and again the same atrophy. So we are more or less certain that this is a mesial temporal sclerosis. Dr. Ashwini, would you like to add up anything? Okay, so next. So we have a clinical semiology which has ruled out pseudo-seizures, at least in the epilepsy monitoring unit. The seizures are all focal seizures which are dyscognitive, where she does not respond initially, then responds with a lateralization to the right side and a localization to the temporal lobe. The video EG is right temporal, T4, F8 T4, and of course there's right MTS, and she had a PET which had shown hypometabolism of the right temporal lobe. And so it is concordant for the right mesial temporal epileptogenic zone. Next. And the plan, I will leave it, yes. In this patient, she had preserved verbal memory, and visual memory was mildly impacted, and her intelligence is good, is pretty good. In fact, she's doing her master's in...
She's doing a master's in Marathi literature.
She's doing her master's in Marathi literature. So she is a very well-functioning, high-functioning individual, and that will decide our plan for the intervention. The intervention could be a amygdalohippocampectomy, anterior mesial, or a laser ablation. Dr. Ashwini, would you like to add to anything?
Cover this later.
Okay. So next. So the next patient.
The next patient is Vikash. He is a 24-year-old male, and he started having seizures at the age of 11. at the rate of now, at presently, the frequency is 1 per week. The semiology is that he has an aura which is ill-defined, and he has some bimanual automatisms in which he appears to be praying, and there is some verbalization which appears as if again he's muttering some prayers, and he also has in some occasional seizures blinking and chewing movements.
So anybody would want to guess whether it is dominant, non-dominant? Go back to the seizure semiology. If this history is given to you by the relatives, the aura feels something is going to happen, then he prays and he mutters some prayers. He actually prays and mutters prayers. He's muttering during the seizure and he's praying during the seizure, and becomes unresponsive with some blinking and chewing movements. So if a person is actually verbalizing prayers during a seizure, what would it indicate? Non-dominant, probably non-dominant involvement.
So his past history was that he was one of the twins, and there was low birth weight. No definite history of perinatal asphyxia though. Developmental milestones were normal and there were no febrile convulsions. However, there was history of head trauma at the age of 10. After which he had some few minutes of loss of consciousness, but no deficit. There was no encephalitis and family history is negative.
Is
He
the
was
history
on,
of head injury important? So there are certain antecedents which occur in mesial temporal sclerosis which you should take as a clinician. The commonest antecedent is 40 to 60% of them may have history of febrile seizures. So in infancy, in childhood, by 3 to 5 years, they may have fever with seizures. And often they have complex febrile seizures, or they may even have had a febrile status. The second commonest is in our country is history of febrile encephalopathy with encephalitis is the second common antecedent of mesial temporal sclerosis. And the third common in our country is head injury, because many of our children play on the roofs of villages and they fall off the roof or they fall off the tractors, which is what had happened to this person. So they develop this mesial temporal sclerosis, and sometimes there is no antecedent also. In about 3 to 5% to 10% patients, you may not get any antecedent childhood history also.
So this patient was on oxcarbazepine 450 milligrams and 600 milligrams, levetiracetam 3 grams a day, and clobazam 10 milligram HS. And he still was having 1 per week seizures. And his neurological examination we did not find any deficits. So now we'll play the video of the events which we recorded.
So he comes to know he is having something, he calls his brother. So he has this aura, he feels something is coming, calls the brother. That would again go for a temporal lobe, mesial temporal lobe. Different kind of auras are there for different locations of the brain, lobar. So he joins his hand, and because he had this history of praying, the brother thought maybe he's having pseudo-seizures or something, and the protocol is whenever they suspect pseudo-seizures, they'll look at the pupils, they'll do pseudo-seizure testing, which is hand-over face test, etc. And so he keeps his hand in that prayed position, and he keeps rocking backward and forward. Now it's very difficult, if people don't know about epilepsy, they'll probably think this fellow is psychotic or something, and he'll end up with a psychiatrist. And he started his prayers. So he started mumbling prayers. I think he says the Hanuman Chalisa or something like that. And he keeps doing this. So he's being asked to memorize 2 words. Brother is asking Baya haath kaun sa hai? So he is kind of responding, but in the beginning he was happily muttering his prayers. He's even pulling the brother, he's responding. So for him, these episodes are around 1 per week. How many were they?
1 per week.
And he's being he's not able to work and function in society, though he's not a very high functioning person. He's confined to the house because of these episodes. So they are disabling for him. Epilepsy surgery is to be done for disabling seizures, and there is a definition of disabling seizures. We'll come to that. Disabling in whose perspective? The physician's perspective or the patient's perspective? We'll define that later. And that's the end of his seizure. And he responds pretty well after the seizure. And so we recorded I think 4 events in his case. Again, he starts his prayers. He's not responding right now. Sister's asking him to lift the hand. He doesn't lift it. Sister's asking him there. His prayers have started. So these are the peculiar automatic kind of complex automatic behavior which he does. And hereby you can hardly lateralize this in terms of motor lateralization. But the fact that he brings out speech and the fact that he recovers immediately would go towards the non-dominant hemisphere, and particularly it's a very prolonged episode and he responds immediately, so, and it's associated with complex automatisms, so it's non-dominant, so he's recovered. So here we see the ictal EEG, and anybody can identify. I'll give the mic to them. So the neurosurgeons by now, after seeing one case, have become very familiar with identifying the discharges. So anybody wants to identify if there's anything abnormal on this page? These are of course eye blink artifacts. So what's happening here? Here everything is okay, but here you can make out, for the neurologists they will have to identify this, and there is a ictal rhythmic activity which has started here and it is preceded by some kind of spikish activity, and it's almost like a equipotential at around T4. There is some rhythmic activity here, there is some rhythmic activity here, and there's equipotential here. And then it evolves. When you find it evolving, it's clear? It's again the non-dominant, the blue here is the non-dominant, is the right side. And again it evolves and it ends. So that's his MRI. So pretty much like the previous MRI, but here what are we seeing? There's a little difference here as compared to the previous patient. Anybody wants to see the difference? There is of course the same atrophy. There is loss of these undulations. There's a little wider volume, but the temporal lobe really doesn't appear too atrophied here, as unlike the previous. Next. So again, the hyperintensity which is seen here. And of course, you can see that here there is, this is a normal metabolic area, this is a hypo metabolic area, so it's concordant. So again, the choice will be with the surgeons, what they want to do. And I think Dr. Ashwini will deal with it later. So we go to the last patient. Which one? The PET? Can you go back to the PET? This? Please go back. This one? You know, sometimes, yeah, sometimes in flare, no, no.
See, selective amygdalo has been, in vogue for a long time, and as we know, Professor Yasagal propagated it. But by and large, the large meta-analysis around the globe, they show that the results by and large are better for an amygdala hippocampectomy. The reason is, it's not just a focus, it's a network. So epileptogenesis is a network. And the network, they say, is most important hippocampus and of course with amygdala. And these are the two substrates which we'll be tackling with laser. And equally third, may not be so important, is also the entorhinal cortex. So unless all these three are removed, the patient then will go ahead to have the best possible outcome. Ash, you want to make any comments on this?
Just one clarification. So when people look at what maybe not be discussed all throughout is that some patients actually have mixed pathologies, right? And the first case showed you that at least 10% radiographically has mixed pathologies that we can identify. And there are a lot of patients with dysplasias that can't be identified. So when you look at all the results of complete temporal lobectomy, now I'm talking about standard anterior temporal lobectomy, either non-dominant 2.5 to 3 centimeters and dominant 5 centimeters, there's probably a 5-10% better seizure freedom rate. Now, if you think about the radiographic mixed density, that makes a lot of sense. Now, the issue with the selective amygdala hippocampectomy is really neuropsychological function. Now, in a right-handed dominant person like this person who has preserved verbal motor skills, and this is right temporal lobe epilepsy, at least in our center, we would, if we didn't have laser ablation, and I'll talk about that last, we would offer this person not a selective hippocampectomy. You want to maximize seizure freedom rate, and the maximum seizure freedom rate is going to be a standard ATL, a standard anterior temporal lobectomy. And the radiographic findings that you're saying, I don't think we have the technology and understanding to identify how much of that cortex might be dysplastic. The T2 shine through, like even if you look at the insula on the right side, it looks brighter than the insula on the left side. So there's a lot of T2 flare shine through that makes your interpretation of the flare signal sometimes difficult depending on what scanner that you're doing. It gives you an artifact that is hard to normalize around. So the question really I think should be asked is complete temporal lobectomy versus selective amygdala hippocampectomy. And that question really should only come up in the dominant hemisphere. In the dominant hemisphere, a selective amygdala hippocampectomy, the patient has a lot to gain, but potentially at the risk of some seizure outcome. And that, depending on where they are in the neuropsychological decline, may or may not make a big difference. Now, philosophically, we have actually started offering any patient with mesial temporal sclerosis. Now we've done it for 4 years. We offer all the MTS patients laser ablation first. When we looked at the neuropsych consequences of laser ablation versus ATL versus selective, it's actually better in every case because you're not doing any cortical destruction. And surprisingly, you're also sparing a lot of the entorhinal cortex. And I'll talk about that a little bit later about the entorhinal cortex portion. But like Sharath said, you don't know going into this if the network is involving also, when the first patient had epigastric auras, the amygdala is definitely being involved. In that person, we would try to do actually a more aggressive amygdala resection to try to get an angle 1 rather than an angle 1A outcome because the patient has the epigastric auras. And it's hard to know how much the entorhinal cortex or amygdala, is involved. There's no doubt that the outflow pathway of this circuit is hippocampus. So I think even if you do a good hippocampal resection, you're going to get good results. The question is how to get that extra 10%. And I think that's where the nuance of the epilepsy surgery sometimes comes in. But I think for anybody who's starting their program, if you do a good hippocampal resection, you're still going to start off by having pretty damn good results.
Next slide. Next. So the last patient, Dr. Reema will be presenting.
Respected teachers and dear colleagues, I'll be presenting the last case. Vivek Das is a 35-year-old gentleman. He has normal birth and developmental history. His seizure onset was at 9 years of age. His duration is 26 years and frequency is 3 to 4 per month. His semiology is, he has a very ill-defined aura. He has visual blurring and followed by he has confusion and bimanual and oral automatisms with slurring of speech. At times, he also has complete loss of speech, ictal loss of speech. The drugs that he is on sodium valproate 1 gram per day, levetiracetam 3 grams per day, and lacosamide 350 milligrams per day. So clinically, if we could diagnose, he is drug refractory, dyscognitive seizures. We cannot definitively lateralize based on the history, neither on the aura, because it is not definitely lateralizing. Probably of temporal lobe origin, because even he has prolonged seizures. Video EEG.
But there is a red flag. We have consistently asked him about the aura, and he does not describe. Usually in the mesial temporal, you will get an aura of an epigastric rising or sinking sensation, or maybe you get a déjà vu or Jamais view, or you get those kind of auras. Sometimes you can get an olfactory aura. But this person consistently, and he's educated, he's a teacher, he consistently says that he has visual blurring. So visual blurring is kind of a red flag here, because visual blurring would arise from either the posterior temporo-occipital junction, that area, or sometimes you can have visual blurring even in
Precuneus.
precuneus, if there's a lesion in the precuneus or in the posterior cingulate area. So these are red flags for this patient, and we have to keep it in mind while reviewing the radiology, and the radiology was reviewed by Dr. Ajay, so we'll be coming to it subsequently. So we go to his events. So he comes to know he's going to have something, so he removes the blanket because he's been told he has to remove the blanket when he has. So he does perceive something. And at that point of time on testing, when the technician asked him, was it double vision, he definitely said no. So though he complains of visual blurring, we don't find it happening in the visual epilepsy monitoring unit. He's actually listening to what the technician is saying as of now. And he even tries to write things in the beginning. So in the beginning of the episode, he's kind of trying to do what the technician is telling him. And then you can see what's happening to his right hand. The right hand is doing some peculiar movements. So these are the kind of movements. So he keeps moving his movements. Are these clonic movements? So he has these movements. And he also has fisting of the right hand. So you can clearly see that the right hand is fisted. It's a fisted right hand with these flailing kind of movements. This is a phenomenon which has been described by
Ben Badis, and it is called wrench.
It is called wrench. It's been described by Ben Badis et al. And if you have a fisted hand along with rhythmic ictal non-clonic hand movements. So wrench full form is rhythmic ictal non-clonic hand movements. And in a patient, then again the lateralizing value is
50 to 60%
contralateral. So it's a contralateral phenomenon here. So the right hand was in wrench and with fisting of the right hand. He is not able to understand what the technician is telling him, not comprehending. He's not reading, doesn't read. He's being asked to read, doesn't read. But then this one, at the end of it, it finishes pretty early. He doesn't remember the 2 words which he was asked to remember. The technician gave him 2 words to remember. He doesn't remember. So he fails on the verbal memory. He's trying to, but he doesn't remember. So another episode just to see that they are, so you have to say that they are stereotyped. The purpose of recording at least 3 events in these cases, the mesial temporal, would be that they have to be stereotyped. You cannot have events which are different from each other in every episode. And hence we try to record at least 3. Again he gets up, he comes to know something is going to happen. But again this is no visual blurring. And again you see the movement of the right hand. He is initially obeying the technician, but then again the right hand goes into a kind of non-clonic movement which is rhythmic. So wrench with kind of fisting. And there is some posturing now of the right hand. He's obeying commands, which is good. Simple commands. But reading he fails on again. So the hand is still, his hand has gone to the back with some kind of fisting. He's still confused now. Not able to read, not able to identify. Well, it's not moving as much. So there are 2 things. One is relative immobility and one is paresis. So he is actually lifting it and leaving it, lifting it and leaving it. So we would say it's a relatively immobile hand with a wrench-like phenomenon, not a paretic hand. A paretic hand would be just paretic. So relative immobility of one hand is also a contralateral sign. And then his hand is still kind of postured, but then he is okay by now. So the lateralization here is to the left side. Laterality is the left, and of course because the episode is associated with loss of reading and speech, though his comprehension is preserved at least initially before he gets confused, it would go to the temporal lobe. And as you can see here, the ictal onsets. This is an average montage. And The upper are the left-sided and right. And you can see here, the ictal rhythm starts with a slowing which happens right here at this second. And there's slowing here which progresses with the highest amplitude again at F7. And this is how it progresses further. And this is just to show you the further progression. Again, this is a bipolar montage. The red is left here. And you can see here there's some slowing which comes in here, which is around F7T3. So this is the slowing which comes around F7T3. Again, seen in the average montage for the same seizure. And this is how it kind of progresses. It spills over to the right later, of course. So this is his MRI. Anybody would like to read it? Any resident would like to read it? Neurosurgery resident. So you can see, good, very good. Pes hippocampi undulations on the right and completely missing on the left. It's atrophied, volume is increased. And of course, look at this whole left temporal lobe. This is good white matter. There is hardly any collateral white matter over here. This is the collateral white matter. There's hardly any collateral white matter, and it's atrophied temporal lobe. So this is, next slide. So again, seen here, you can see the undulation's pretty good here. Same thing seen here. Next. Again, seen here. Next. So his intelligence, as per our AIMS neuropsychological battery, was around 78%, which was average. He had a mild verbal memory, which was impacted, which was brought out even on testing. And when you talk to the patient says, yes, he does forget things. Yesterday, in fact, bedside, he was saying, will it get worse? So he is pretty concerned about his memory following whatever procedure is done. Next. His PET shows a pretty fair mesial anterior and mesial temporal hypometabolism on the left. There's no hypometabolism which is seen laterally and posteriorly. This is because he was complaining of this visual blurring and we were looking for anything in the parieto-occipital junction. So that is pretty okay. So predominantly here. Next. His functional MRI has been done by one of my PhD students whose work is on that, Kapil. And Kapil is here. So Kapil will explain his functional MRI.
So in this patient, we gave a semantic memory task, and patient showing the bilateral posterior superior temporal lobe activation. In the task, we gave some word to the subjects to remember the words, and after 10 minutes, patient replied the asking words. So we can see here the superior temporal lobe activations in the right side in pre. This is right hemisphere and this is left hemisphere. So bilaterally patient recruited bold activity.
Then he went on to do a complex comprehension.
Yeah, in this task we gave some jumble sentences to the subjects, and patient recruited bilateral superior temporal lobe activity.
So he was having a comprehension which is even shifted to the
right side.
there is some amount of shifting which is seen to the right, though it is less as compared to the
Yes.
next.
So this is word generation task. In this task we gave some simple words to the subjects, and patient recruited left inferior frontal gyrus activity.
So that area we are not going to touch in the surgery.
Yes.
Thank you.
So like Professor Sharan was telling, it's very important when you are assessing a left-sided dominant mesial temporal. If you see it, you should not just jump and go and do it. You can end up having a patient who can be severely compromised neuropsychologically in terms of verbal memory. So in India, it's not possible for us to do WADA. Sri Chitra is an exception of two reasons. There is lack of paucity of availability of sodium amytal, and plus all centers do not have a neuroradiological facilities. If they have, WADA is one of the least interested in doing. So it's very important to develop other modalities. So we have never done WADA. We have developed our own protocols for fMRI, and we found that this is very, very reliable. So using fMRI, we can find out which is the area of comprehension, which is the area of motor aphasia, which is the area for memory. And if it is bilaterally represented or it is much more posterior, then we can be very reasonably certain that if you do surgery, patient is not going to be compromised. Now in this case, I would prefer to do a modified amygdalohypocampectomy with anterior lateral temporal lobectomy. I do not do a selective, not because we have not done it in the past, but because our own experience was not good. The reason is that most of our patients, they come after a long duration of epilepsy, and they have something called as pathologically, they say it's Chaslyn's gliosis, where even the lateral temporal lobe gets atrophied because of constant. Now if you see the epileptogenic networks, the concept of epileptogenic network is very different from focus. I'll explain to you in a few simple words how it is different. A focus is said to be static, so it is always there. So if it is 2 centimeter size of focus, even after 10 years it is going to be 2 centimeters. But a network is different, it's dynamic. It expands over a period of time. How does it expand? It expands by taking in. So the way the epileptogenic network expands is, let us say you have a neuron at point A. It stimulates the neuron at point B. This neuron once again comes back and stimulates the neuron at point A. So they form a network. And if it goes on for some time, now this neuron will now go and stimulate a more distant point at point C. And that will once again come and stimulate both A and B. So over a period of time, it's dynamic, it's expanding. So if we consider networks, I'm not very happy seeing that atrophy temporal lobe. I feel most of it should come off. And the other thing is, even our experience, we have seen whenever we have done selective, we have had failures. And we went back and we did an anterolateral temporal lobectomy. We subjected that to histopathology and we found type 3 cortical dysplasias. So we feel that it's always better to do, like Dr. Sharan was telling, a standard amygdalohypocampectomy with anterolateral temporal lobectomy, which is what we'll be doing, and I will also be telling you a lecture on how it is to be done.
I think in 2 patients, Chaitali, who's doing her master's in Marathi, and this patient who's a teacher who's very apprehensive about his cognitive deficits. I had discussed.
We are doing laser ablation.
Yeah, so we had discussed with Ashwini, and because of their high functioning and their apprehension for deficits, cognitive deficits, we thought we would do a laser ablation for Chaitali and the last patient. The second patient is Vivek, Vikas, yeah,
Vikas,
and in him we would be doing an open.
Which one? See, a laser, I will ask Ash to comment.
No, I think you're exactly right, is that you're compromising the success of surgery at the expense of preserving neuropsych. Now, in somebody who's working, I think you have to preserve the neuropsych. If somebody is a laborer, so you have to do a balance, right? Because you'll give him a better seizure outcome, but a 10% decline in the verbal IQ means that he's not going to be working, right? So that's the balance. Now, if somebody's a laborer, they're probably going to be able to work in both scenarios. Yeah.
In centers who are not doing selective, those who are not doing laser, their name is
Yeah.
last reason they have had lobectomy and right side lobectomy. Have they shown the verbal IQ or the speech or the memory which has gone down? In our experience, we had many left-handed cases, and I don't think we have seen that kind of effects.
Yeah.
Yeah, I like to answer that because we have been doing anterolateral temporal lobectomies and we do it. The first question is, answer to the first question is, if you do a very good workup, like we have done it for fMRI, and you show that language is very much away, it's in the posterior superior temporal part, and you do an anterior lobar resection, you're not going to end up most of the times with any kind of deficit. Number 2, regarding your deficits, most often you cannot find them just on clinical examination. You need a detailed neuropsychological examination. That is when all these subtle points are going to come out. Surprisingly, many times they don't. They say they are having some difficulty in coping up tasks and everything. And when you subject them to neuropsych assessments, you will find out what are the areas where they are having difficulty. And then you will come to know, yes. But this doesn't happen. Fortunately, this doesn't happen if you do a very good workup.
One corollary to that. So we also do neuropsych on everybody, and the battery is very difficult for patients to do. But I think what you want to identify from a practicality is the working person. You want to get the neuropsych on. Maybe perhaps if you want to do it in a cost effective, we do it in the US, we do it on everybody because we think that we have infinite resources. But in the absence of that, the working person, I think you should get the neuropsych more formally on and make the decision. And then the reason you haven't seen deficit is because to work, most people don't need a full neuropsychology. Most of your skill sets are learned and they're not short-term memory based. So if your skill sets that you require to work are long-term memory based, then you're not going to see a big consequence. And when you get neuropsych on these patients, I'm amazed at how many engineers, teachers, lawyers that I've operated on, even physicians, their IQ is less than 100. Now that doesn't make sense. As a physician, you cannot have an IQ of less than 120. But by the time that they've had epilepsy for 10 to 15 years and they come for surgery, the chronicity has allowed them to compensate for that deficit, which is
I'd
why
like
you
to
don't see
thank
it.
Dr. Bhargavi and sorry for interrupting, Ash. They have to rush for a neuroradiology conference. I have to leave too. So any neurology questions, we'll take them over lunch. And
Okay, thank you very much.
tomorrow we'll be back with the other cases.
Thanks to all the three of you. So now I will request Professor Ashwini Sharan to give us a lecture on the laser ablation.
There is an announcement that the neurobiology lecture will be held between 2 and 4 the seminar room on 6th floor.
And really thank Sarath and Manjari, for the opportunity to come here today. And I want to start by telling everybody here who's interested in starting their epilepsy program, and I apologize for the voice. I don't know how I got this URI coming to India. But when you're starting an epilepsy program, I think one of the most important parts of the epilepsy program is not just as a neurosurgeon running it, but having an incredible collaborative relationship with the neurosurgeon and neurologist. As a neurosurgeon, it's not practical for you to screen out every single patient who's going to come to your office. You need a team of individuals. You need the neurologist to help you identify the pseudo-seizure patients, because 20-30% of those patients, at least in our population, every patient that we admit to the unit, 40% of those are pseudo-seizures. It's actually, I'm always amazed at how much psychological problems there is. And then when you're trying to tailor an epilepsy operation like we were discussing, you really need access to a neuropsychologist who can help you make that best decision. Because patients will make decisions, and as physicians, we know some answers, but I don't think we know all the answers of how the neuropsychology relates to how the surgery should be tailored to that patient. And this is where laser versus selective versus ATL are options. And so that relationship that you established with you have to trust your neurologist, you have to trust the neuropsychologist. And there's another portion that, the Institute over here has, and what I think the world is understanding right now of epilepsy, it is really, for anybody who has this academic interest, it is actually the truest collaborative disease process that we have. Because there's an incredible scientific component that's in epilepsy. There are almost no situations in the world where you're electively taking out so much brain tissue. When you're doing it for tumors, trauma, it's a non-elective situation. This is an elective operation, so there's an opportunity to study the brain, study the neuronal structure with electron microscopy, study the patients when they're in the EMU, when the seizure unit, to study actually brain mapping. Today, the science of the brain is about to accelerate because now we have this collaborative relationships like with Aparna and Jyotmer at an institute. So it's an incredible time, and for everybody who's interested in starting an epilepsy program, get that team together right now and start this work, because in at least my opinion, at least in the United States, we're going to see the rate of epilepsy surgery double and triple right now inside the world, because this is not your normal brain surgery. What the public does not know is when you look at complication rates for head trauma, ruptured aneurysms, bleeding in the head, brain tumor surgery, if you look at all those complications, I mean, talking about serious complications, you're talking about 10 to 20% complications. That is absolutely not true with epilepsy surgery. By and large, serious complications from epilepsy surgery is on the order of 1%. Because this is very controlled, very elective surgery on actually relatively healthy patients, right? From age 20 to 40. And the public does not know, when they compare a craniotomy, they don't understand what the neurosurgeons in this room understand, that this is not your 6 centimeter acoustic meningioma or big frontal meningioma type operation. This is just not that surgery. This is very controlled, where the point is that we're debating between a 10% seizure freedom rate and we're debating between a 10-point IQ rate. So that's that fine and that precise. So with that, I'm going to talk to you today about laser ablation. When Sharath actually asked me to come to India and said, what would you like to demonstrate? I said, gosh, man, I don't know. I don't know what I can teach you in terms of an operative technique when it comes to just pure neurosurgery that everybody would find interesting. And in that, I thought that this laser ablation that we're doing now would be of the most interest, to be honest, because we've been doing it for 4 years, and at this point, we're no longer offering patients selective amygdala hippocampectomy through a craniotomy. If we do a craniotomy, we're doing a standard anterior temporal lobectomy with 2.5 centimeters resection of the anterior temporal pole, the entire pole, with the amygdala and the hippocampus. So in the absence of that, when we're thinking selective, we're only doing laser ablation now. And we've evolved at our approach, and I'm going to show you a little bit of that as a transformation. And just to tell you that India is incredibly advanced, I came here not just to give the lecture, which I'm honored to do. I came here so I can learn how to do endoscopic functional hemispherotomies. This is an application that we probably have no experience in. And in this country, once you guys start doing any type of operations, your numbers far surmount our experience that we get in the United States. So in a way, it's actually a lot of fun. Now, I think we talked about this, and I don't think that we emphasize it enough. And I don't know if you emphasize it here enough either in India. But there's two things. Besides the impact to daily life of epilepsy, which it interferes with their school, their work, talking about, what is a disabling seizure in terms of anxiety and the distress to the family. But we also emphasize SUDEP. We emphasize the fact that there's probably this 0.5% rate when patients have intractable complex partial seizures or generalized seizures. There is also a death rate in young people that is associated with this disease. So that fact, I think, should be out there, coupled with how I told you that the morbidity of epilepsy surgery is low. And I don't think that these two things are actually explained to patients. And the third aspect that I don't think is explained to patient is that although everybody wants to take a small pill and be cured, once you fail 2, 3, and most patients we get fail 6 medications before they get to us. And that's our number at our center. I don't think people understand how invasive drugs are and how many side effects that they cause. And with the good operation that I'm going to show you today about the laser ablation, there is almost 0 side effects to that operation, and it's an in and out. It is what people expect from surgery. People expect surgery to be seamless, short recovery, 0 complication rates, and good results. And drugs in this population cannot offer even a 10% cure rate, right? They cannot offer a 10% cure rate, and that's just not emphasized. So I'm going to continue. And then this was a big paper published in 2001. It wasn't mentioned today, but we have RCT data that shows that if you randomize patients, now this wasn't just mesial temporal sclerosis. So in this study, the surgical group had a 58% cure rate, as opposed to the medical group, which had that 8%. I told you less than 10% cure rate, okay? But we also have the data to show that surgery is safe and has great results. Now I'm going to set the stage for laser ablation. Doing a craniotomy is good, is precise, it's controlled, the hemorrhage rate is low, the stroke rate is low, but in anterior temporal lobectomy, you got to admit, cutting the muscle, the temporalis muscle, although it heals, cutting the bone, taking that much brain out does not seem like the most natural thing to do. Most people in this room, because of the intellectual nature of this crowd, would probably want to refrain from having that much of their temporal lobe put into the garbage can, right? Even if it meant for seizures, everybody in this room who knows how bad seizures could be and what the consequence of it might be living would think twice about this surgery. And even the neurosurgeons in this room would think twice about the surgery. So how can you expect the public to want neurosurgery, okay? The neurosurgeons won't want this. The neurosurgeons also talk about the same thing with endovascular versus clipping, right? You know that the cure rates for clipping are higher than endovascular, yet almost every neurosurgeon in the world that I talk to, if they all say that if I could be coiled first, and price is not an expense as an issue, I will be coiled. I don't want people touching my brain. Okay, so then why do you want to touch people's brains? So this is the compelling argument that I actually felt. That was why I think I've adopted really hard to the laser ablation method and why I'm adopting to the less invasive surgical approaches. Nobody, even the neurosurgeon, wants their brain touched. Okay? So unless you lead by example, don't give that to your patients. So I'm giving you this just a little history, standard ATL approaches, and the issues come back from a lot of literature when we did a lot of brain mapping on memory and language and saw that there's a massive amount of variation, and this is a paper by Haglund and Ojman's group, talking about what percentage of patients have reorganization of language function in their temporal lobe. And that's how people got into this thing about doing selective anterior temporal lobectomy. Spare a lot of superior temporal gyrus, try to spare the entorhinal cortex whenever you can, and because these are all structures that are involved in memory. So surgeons have been going for 50 years towards this less invasive approach. Interestingly enough, Paulo Niemeyer, who did most of his practice between 1970 to 2000, his 30-year plus year career, he is the one who described the selective amygdala hippocampectomy. And I think it's interesting to know that he developed a passion for neurosurgery because his sister had intractable epilepsy. And he grew up with that lady, and that's what made him so passionate about developing these techniques. Now, interestingly enough, he was also a great stereotactic surgeon. So a lot of things that happen in life and the world is really just refinement of technology and building on foundations that were laid down essentially 30, 40 years ago for us. So I'm going to show you the convergence of stereotaxy and epilepsy because that's where I think the future of the field of epilepsy is, the convergence of stereotaxy and epilepsy. So for the people here who aren't aware of what stereotaxy is, that also is a 50-year-old phenomena. The first stereotactic concept happened in 1954. And the stereotactic concept starts by putting a rigid frame and actually bolting the frame to the skull itself. So there are 4 pins, and you can have any type of frame. There are 4 pins that are actually screwed in the skull, and that creates a target system, a coordinate system, which people call stereotactic space. So you get a fiducial scan. You get either an MRI or CAT scans, which has a fiducial box, which this video won't show. And the fiducial mark is all millimetrically precise attached to the patient, which won't move now, because that device is, as long as your device doesn't get loose to the skull. And once you have the fiducial scan, you define stereotactic space. And this arc is there, and you'll see essentially the concept of stereotaxy is that any trajectory on this arc from any angle, which can also be manipulated at the ring or the arc, will always hit the target once the target is calculated based on fiducial space. So that is the concept of stereotaxy that was given to us 50 years ago, believe it or not, and then implemented. Now, back then, even 20, 30 years ago, when I showed the Paulo Niemeyer slide, people tried to do ablation of the hippocampus. Now, initially, people tried to do hippocampal ablation through a side approach, right? It's a basic core neurosurgery principle that you want to take the shortest path with the least number of sulci or blood vessels that are in the sulci between you and the target, trying to minimize transgression of ependyma surfaces, right? So simple things that actually avoid bleeding risk. Now, unfortunately, when they did that through this lateral approach, you can see they did very small amount of lesioning. In radiofrequency era, you could not tell necessarily that that electrode, before you actually started the burning, was in the hippocampus. If you were lucky enough to see spikes, then it would perhaps convert it. In the DBS era, we do microelectrode recording, which you're in a lot of gray matter. But in this one, in a dead hippocampus, in a mesial temporal sclerosis patient, you may not get as much robust recordings as you think. So we didn't have a physiological confirmation, and we didn't have a radio confirmation that we were in the right era. And then with any one electrode, you weren't able to make tremendous amount of lesions. You know, the effective area that you could burn were these little 1 centimeter areas. And so the results were really poor. In that era, the results of seizure freedom was 10-15%. So Montreal Neurologic Institute, which published this paper, which I'm showing you, abandoned the technique back then. Now, lesioning had a lot of issues, right? In that era, the leads weren't always in the right place. You were essentially working in a black box. It's irreversible. We didn't necessarily understand how to kill the tissue in every areas. We used timers to heat the tissue 45, 48, 50 degrees for 30 seconds, 2 minutes. Everybody had their formula. Now you got to think that the brain, based on the perfusion, which I can talk about maybe in the discussion, has incredible amount of capability to dissipate heat, right? The cisterns, the CSF, the blood flow, all this thing affects heat transmission in the brain. And in the old radiofrequency era, we have no way of understanding that. So in a lot of ways, this is why the radiofrequency was not the right tool for this, as well as the anatomic constraint. So what the laser ablation tool is allowing us is to revisit this in a much more sophisticated manner. A couple of things. In all the laser ablation cases that we're doing, we're approaching the hippocampus through the entire long axis of the hippocampus. Now, just to be fair, this has its constraints also. The hippocampus is a C structure, and you can see that our catheter and our probe is a straight tool. So you have to make some sacrifices in terms of which parts of the hippocampus you can do, because you can't actually mold the entire burn to the entire length of the hippocampus, which is going to curve posteriorly as it goes towards the fornix back here. And you have to make some decisions on, do you want to make the burn a little bit more in the amygdala or the entorhinal cortex? Because you also have to choose either a caudal trajectory or a rostral trajectory when you do that, and I'll talk about that in a second. So the laser ablation tool basically is a near-infrared laser. It can deliver up to 15 watts of energy through this 980 nanometer tool. It has a light diffusing tool. The diameter of this tool, just to give you a sense, this fiber is 1.6 millimeters. So it's a little tiny fiber that you place inside it. And typically you can dissipate and ablate tissue 8 millimeters to a centimeter from the radius where the probe is at. I'm sorry, from the probe, which is the center of that radius. And you can typically make an elliptoid or a cylindrical type burn. And for that, the hippocampus is an ideal structure. A lot of people start thinking about different shaped cortical dysplasias, and I'll look at that in a second. But if you have very abnormal shapes, the laser tool is not as conformal as sort of a gamma knife technology or some other technologies, or even surgery. With surgery, you can conform to any type of abnormality, right? So the laser ablation is very different from radiofrequency ablation. You know, radiofrequency ablation was thermistor controlled, so you can tell how hot your tip is. The laser ablation is MRI thermometry controlled. So with MRI thermography, just so you know, this technique is also not new. MRI thermography has been around for 20 years without necessarily an application. But you can measure the temperature in the brain or any tissue that can have an MRI. As you know, maybe perhaps everybody knows this. I did not know this before 2011, that MRI thermography is that sophisticated. So you can get real live assessment on eloquent and non-eloquent brain. So when we do this operation, where we don't want any of the burn to happen, like yesterday we did a 4-year-old girl with a hypothalamic hamartoma, we put our temperature sensors on the optic tract because we didn't want the temperature on the optic tract to ever be hot enough to cause irreversible tissue damage, right? So you can actually exactly dial in where you want it. Then the other thing about the light, the 980 nanometer, is that it gives you a very narrow transition zone. So within the radio frequency era, there was this dissipation of heat, and you didn't actually know how far the dissipation of the heat would be. And in pathological sections, both in human brain and in animals, the transition zone is controlled to less than a millimeter. So the precision of the laser tool in terms of light energy causing heating is incredible. And it's giving you real-time vision of what's happening in the brain. And also, radio frequency is metal, cannot go inside the MRI. This is fiber optic and can go inside the MRI. So you get visual confirmation of where your probe is before you do a lesion, right? So we're no longer making lesions in a black box. So I don't think there's a doubt in my mind that the technology has transformed. Do I think it's something new? Probably not. I think this is incremental improvement that's happened over 50 years, but it is those foundations that have allowed us to get to this position. So this is what the fiber optic tool looks like. We'll show you later. Once the anchor bolt is actually inside the skull, and I'll talk you through that, we put this catheter piece. This is the probe that goes to the brain, and this is the fiber optic tool that's going to come outside the MRI suite into the machine. The machine that delivers the laser energy is not MRI compatible. To give you a little just review, 60 to 100 degrees is considered conventionally the temperature at which there's instantaneous cell death. So if I take 1 millimeter of tissue and raise that temperature to 60 degrees, that neuron will die for sure. But between 45 to 59 degrees, there's a time-dependent cell death. So, for example, at 50 degrees, if you heat tissue for 30 seconds, you're likely to denature that tissue. So you can sort of control a gradation. Where do you want your sensors to be set to make an assessment for how long you're heating the tissue, because you actually have a real-life timer and you'll have a real-life temperature probe that's inside the brain. Now, I'm going to show you one more point that has happened. When I started training, and this is all part of the evolution, people, when they did stereotactic biopsies, predominantly for tumors and unidentified lesions in the brain, in that era, the literature tells you that there's a 5% hemorrhage rate. Now, I started training in 1996, and at that time, we weren't doing on every case trajectory planning. As a neurosurgeon, we've always taken for granted that most biopsies, which are from a frontal approach, you don't have to be crazy about trajectory planning because the frontal lobe has big gyri, and you can usually enter them without hitting a cortical vessel. And you can typically get your trajectory once you're in the white matter tract, right? The old neurosurgery thinking was that be in white matter tracts, avoid the sulci, avoid the ependema, and you won't have bleeding, right? And that was true for a frontal approach. But now I'm going to show you, how about if we want to get through this posterior approach? You know, the collateral sulcus typically comes really high up, and you have all these little gyral patterns over there, and you know that there are always blood vessels inside the sulci, right? So trajectory planning is an imminent part of everything we do in epilepsy, be it stereo EEG or laser ablation through a long approach. Now, for people who aren't familiar with what trajectory planning is, I'm going to take that back again. So all these white dots are highlighted. Now, I don't think you need to do this with digital subtraction and geography, but I tend to also, in our institution, get DSA. But MRI with gadolinium really highlights all these small sulcal vessels. So basically, you get an MRI with gadolinium, and for those who aren't familiar with what that means, all those things that highlight are blood vessels. So these are the blood vessels that we have to get through the brain and get the probe in. So I'm going to pause this view in a second because it's too hard and I lost my cursor. I'm just going to go back. So we get this this is an angiography, but you can also do it with MRI gadolinium. And we have to find a trajectory that's going to go from the back without hitting any little blood vessel and getting to the target, which seems like a very difficult task. It's not an easy task, but it's a doable task. And the way we do it is on every imaging slice, you want to know that that red dot is not crossing one of those blood vessels. And so I'm going to go through it. So you go through every imaging slice, and once you're happy with the slice, you use your stereotactic arm to insert an anchor bolt. Now, this case I just showed there for demonstration purposes because when we can't localize seizure, we will put up to 16 different electrodes inside the brain to lateralize where the seizure is. For example, that we're doing this one patient with the visual aura, the blurred vision. We will offer that patient an anterior temporal lobe resection, selective amygdala hippocampectomy, or laser ablation. Let's put all three on the menu. But if that gentleman failed, like you heard the neurologist talk about the hypothesis, where can that come from? You'd have to implant the precuneus. Excuse me, let me just. You'd have to implant the precuneus. You'd have to implant the posterior cingulum. You'd have to implant electrodes in the temporal occipital junction, right? Because anywhere from the temporal structures, might have been the focal onset zone, but the whole network and the epileptic genic zone could be that whole entire network. And in an imaging study which can't identify a microdysplasia, the electrographic confirmation is the only tool we have. So in a patient like him, we would do the stereo EEG implant, getting those electrodes. And we would put 16 electrodes all over the brain. Now, that technology is very safe. The track record for stereo EEG over the last 10 years, hemorrhage rates are now less than 1% because of this trajectory planning. And to give you the last sense on how crazy that ends up looking. So once you have all the trajectories in, we always get post-op MRIs. Here, I'll do it here. So these are post-op MRIs, and these black streaks are the different electrodes that are going through the brain, right? No bleeding. We do segmentations, so you can see where these electrodes are. And just to give you the challenge of how that looks, if you take the brain away and through the blood vessels, all these electrodes were safely inserted into the person's brain, and then the brain will disappear in a second. And that's what they look. So we can actually cannulate every part of the brain at this point safely. So the technology is here today that in a patient that needs that done, that should be done. Now, in this patient with a visual aura, we would not do that as a first alternative, right? Because there probably is 50 to 80% chance of cure with removing that gentleman's hippocampus. So I'm going to just walk you through the surgery that we're going to perform. So the stereotactic head frame, this is a CRW frame. Today we're using the Lexel frame, which was the cartoon that I showed earlier. The Lexel frame is already applied on the first patient, and the patient is getting their fiducial MRI from which we're going to plan the surgery. And we'll take you to the steps. But basically, the patient is in the operating room, and the patient's head will be in a little bit of a flex posture, so we can access the posterior aspect of the occipital bone. And basically, the incision point, when we measured our 30-plus cases of cannulating the hippocampus, is about 5 centimeters superior and 5 centimeters lateral to the inion. That is important when you apply the stereotactic frame because this post is inevitably within 1 to 2 centimeters of your anticipated entry point. So you have to take precaution, and you see how these bars can be lowered? This is not the ideal case because this was our second patient, but this post should be as low as possible to give you the maximum working room. So for the neurosurgeons, it's a very big deal. So once you've actually calculated the stereotactic coordinate, the arc is placed on the patient, and the arc holds a drill guide, and this arc wants to be as close as you can to the surface to minimize the precession or the wobbling the drill bit will introduce, because you need this to be a straight trajectory right through the skull, and you create a 3.2 millimeter hole. Once the 3.2 millimeter hole is drilled, you actually enter a stylet, and with the stylet in place, you put the anchor bolt inside the patient. Once the anchor bolt holds the skull, then you have a rigid path, which the stylet will always enter its target, because it's about a 2.5 centimeter pathway from the surface to the skull. So you measure the distance from the frame to the top of this, and you mark out your laser probe, and you just simply insert the laser probe. To insert a laser probe inside somebody's head takes under an hour, and takes a small incision, 3 millimeters wide, and no pain associated with it, and really no bleeding, right? So once the probe is inserted, the patient is actually transported to the MRI. And the most anxiety situation I have is knowing the confirmation that the probe is in the right spot, because the leap of faith is still that every equipment, every calculation that you performed was correct. And in the radio frequency era, we took it for granted, but in this era, you can actually see the entire probe through traversing the hippocampus, and in this situation, we actually go past the hippocampus into the amygdala head. Once we're happy with the trajectory, then inside the MRI, this is real-time thermography, and you can calculate, the machine is actually telling you the actual temperature once the laser is actually being invoked, and then the laser is actually calculating tissue depth, and it uses orange to calculate the tissue depth. Once we're happy with the position, we actually then will start pulling the catheter back, and we'll sculpt the rest of the lesion, at posterior trajectories, and we typically pull it back 2 other times by a centimeter each to get about a 2.5 to 3 centimeters burn on the entire hippocampus volume. And so this is just an example that we've pulled it back, and you can see that the tissue depth is actually done posterior. Now, because of that posterior trajectory and the lateral trajectory, we're really not able to get the posterior tail of the hippocampus in most patients, because most patients' hippocampuses are actually a C. After the burn is done, that's the anticipated burn, we give gadolinium, and since we've disrupted the brain-blood barrier, we get a very nice outline that should correspond with what we thought the computer gave us an anticipated burn. So that's what that looks like. Now, in our group, we've done a lot of volumetric analysis of the anticipated burn lengths, and done a lot of subtraction by highlighting the hippocampus and trying to calculate it, what type of hippocampal burns we can get in what type of anatomy situations. And we've compiled that in our 30 cases. And based on knowledge that we had in our first 10 cases, we changed our approach to this surgery. So when we first started this surgery, we actually did a lot of, so these were our first 10 patients. It's not the, so we actually, you can see that the location of the electrode, I created an arbitrary scheme where I put quadrants inside the amygdala and the hippocampus to try to quantify, did I actually get more of the superior hippocampus or inferior hippocampus, medial versus lateral approach? Because if you're aiming for the entorhinal cortex, initially we were under the impression that it's more important to get parts of the hippocampus and parts of the entorhinal cortex, because that's considered to be part of the outflow pathway of the epileptic network. So we wanted to try to get the onset zone and the network, the irritative zone, and hypothesizing that the entorhinal cortex was a major component of that. So we always came in with a little bit more superior trajectory and a more inferior approach on the hippocampus. And as a result of that, we had a lot of early failures. So we had to reoperate, not reablate. We actually did craniotomies, and those patients were cured after their craniotomies. Subsequently, we've actually gone to a superior medial approach. So what I mean by a superior medial approach is we aim the tip of the electrode to go a little bit more from the head of the hippocampus into the amygdala. And with that, we're hitting 60% seizure freedom rates. And that's also been true for the first 3 centers, which was essentially us, Emory, and Texas Children's.
We all made the same mistake. We all came together in the beginning and said, let's go for the entorhinal cortex. And when the seizure freedom rate wasn't as high, and I'll show you the data, we switched to this superior approach, and we've gotten better. So that's part of the learning curve that I'll save you the learning on. In our first 10 patients, the length of stay on every single patient was 1 day, and patients went back to work in 3 days, right? Which is unheard of in a craniotomy setting, right? Mild headache, and only one patient had some decline in memory, and probably wasn't from the MTS, probably was from his anxiety disorder. You've seen a lot of slides of mesial temporal sclerosis, and that's a 6-month post-op MRI to show you what the cystic cavity looks like. And this is going on the coronals. So you can see a little bit of amygdala spared over there, but really the hippocampus. This operation looks like any conventional selective amygdala hippocampectomy would look, without removal of most of the entorhinal cortex or the anterior-temporal pole, and really no tissue edema. If you start getting post-op MRIs on your ATLs and your selectives, you'll actually also see a lot of gliatic tissue from wherever the surgeon retracted. And in this one, there's none of those adverse effects. And you can see that we can't get to the posterior hippocampus. You see the colliculi, and you see some posterior hippocampus spared. But you can see that we're in here's the front of the peduncle and the brainstem, and the middle, and even in the middle of the peduncle, we can get the hippocampus completely resected on the dominant side. So that's the magic that the laser ablation system actually gives you access to at this point. So after we started doing this in 2011, in the next year, we had sort of this consortium of 10 centers get together and pool our results. And that was actually presented in 2013 at the AANS meeting in the United States. And I'm going to share those results with you. And this is accepted for publication, and it's going to be coming out shortly, because now that we have 1 to 2 year follow-ups on the majority of the patients. So interestingly enough, we wanted only mesial temporal sclerosis patients enrolled in the study, and some centers put in their atrophy, without true mesial temporal sclerosis. Some people put in a few DNETs, and there were even a couple of patients who were MRI negative. So that is such is the issue of trying to coordinate, multi-center studies. So in this group, we had 69 patients, complete a 6-month outcome. This was in December of 2013, and 36 patients had completed over 12 months, with some patients, covering a 2-year outcome. And the Engel 1 outcome at that time was around the 50% rate. Now, remember that when we did this study, the first year, we actually were aiming everybody toward that inferior entorhinal cortex. And we changed our approach mid-study. So when we did a sub-analysis of the patients that were implanted early who were ablated early in the course of our learning versus late, we realized that at least late in the course, it's looking like we're going to have 60 to 70% seizure freedom rate with laser ablation. Now that we've become both wiser on the trajectory, and we've actually learned a lot about the tissue heating, which I'm going to talk about briefly now. So initially we were scared. How much can you burn the brain? How much wattage will be detrimental? And you'll see later today, we will take this right to 60 degrees Celsius inside the brain. We were afraid that 60 degrees Celsius, gosh, if it hits the enterocortical artery, you're going to get a massive infarct and hemiplegia. So we started putting temperature sensors on the enterocortical artery, and believe it or not, that won't even heat up 2 degrees in the cistern, and because of the blood flow. We started putting sensors in the posterior ventricle to our burn, and believe it or not, that won't heat up more than 5 degrees. So the brain's capacity to dissipate heat is astronomical, right? It's designed so that when you have a fever, you're not going to die, right, until you get a temperature of 108, right? The brain can tolerate 105, which is probably 43, 45 degrees Celsius, and even some more than that, right? Because people don't die right away at 108. So it's because these structures are incredibly protected by this capacity of heat course. So I think as we've gone along the laser ablation curve, we're actually ablating more aggressively, and that's how you're seeing such an incredible hippocampal removal. The interesting next step in the learning curve is going to be how to ablate a little bit less aggressively so that you don't have to take collateral tissue with you. Seizure freedom rate, when we do sub-analysis on different pathologies, is all over the map, but the numbers are too low to make a conclusion about, so I'm not going to go there. Almost every center in the United States is actually discharging the patient home the next day. A few centers kept patients early on in the course because they didn't understand how much edema and headaches might be occurring. We routinely give every single patient Decadron, dexamethasone for 7 days to deal with the brain edema. Early on in the series, there was a few interparenchymal hemorrhages. When you're doing this posterior approach, you have to do a full dose of gadolinium. If you don't have a gadolinium MRI, you cannot enter through a posterior trajectory because inevitably there's always this little occipital vein that drains into the tent at that location. So you got to see where that vein is, and sometimes it will affect your trajectory. It will make you take more of that inferior approach or superior approach, and you have to decide if you can live with that or not. But that vein will change that, and that's what the interparenchymal hemorrhages were at 2 different centers, and one of them probably went towards a bigger subdural. We've actually had one case of interventricular hemorrhage, and that was from Emory over here. And I don't think that has any consequence because that blood dissipates really fast. Some patients had homonymous heminopsia, which is very concerning because that's from the occipital approach, or if the catheter was too medial, and got the optic tract. A few patients had superior quadrantranopsia, and I think that's commensurate with any selective or any ATLs. And a few patients had some minor complications. Now, like everything, once you have a new tool, you want to use it for everything. And just to tell you that this is where the nuance of epilepsy surgery becomes. If you have enough tools, you have to use the right tool for the right patient. One of our early patients was an MTS plus, and she had a big cortical dysplasia. Now, she had a very preserved neuropsychological battery with a functional IQ of 96 and a verbal IQ of 103. And we were thinking that if we could spare injury to her entorhinal cortex, now arguably her entorhinal cortex is completely destroyed, right? Her amygdala is completely abnormal. Her hippocampus is already abnormal. But we felt that if you could spare her an anterior temporal lobectomy, that she would have a better neuropsychological consequence. And she had your normal 4 to 5 hertz, rhythmic. Now, I didn't filter out the artifact from the blinking and the chewing, but she had your normal classic, epilepsy. And to try to get a little bit of the dysplasia zone and the head of the hippocampus, we chose a very lateral approach. So it's not clear to me if it was just my surgical approach that didn't allow this girl to be cured, but she had a multitude of seizures after surgery, and we gave her 3 months to see if it would settle out. And it didn't, and we took her back for an ATL, and a big aggressive ATL and getting the dysplasia segment, and she's been cured now for 3 years. So we sort of took, now interestingly enough also, neuropsychology is preserved, right? So the reality is her cortical dysplasia and her long-standing congenital problem reorganized her brain, and her dominant hemisphere effectively was probably her right temporal lobe. So I probably did not do the best first operation on her, but I did a better second operation on her. So the caution point and why I share the case with you is sometimes we talk ourselves into less aggressive approaches when it's not necessarily the best approach either. So that balance has to be done with the patient for sure. In the United States, this number is accurate as of November 2014. And November 2014 is an interesting problem because that's when the company who developed the laser, they're called the Visual Lace, was acquired by Medtronic. And so now that it's a multi-billion-dollar international corporation, they have different rules, and we can't acquire the data the way we did with this small startup company. So the startup company gave me this data as of November 2014, and since 2011, which is when the first case was done, 577 patients have been treated with epileptic focus, 290 MTL, 100 hamartomas, and about 100 focal cortical dysplasias. So it's becoming really a preferred treatment inside the United States for many lesions. And centers are really pushing the envelope now. Centers as Emory are doing cavernomas with laser ablation and actually getting good results, seizure-free, for 12 months, ablating that. Cavernomas in the frontal lobe. Extensive cavernomas along the floor of the temporal lobe. Cavernomas in the uncus. And basically cavernomas all over the body. So I'm going to wind up the talk and get ready to show the case and demonstrate that live for you, but I want everybody to realize right now why this is the renaissance of epilepsy surgery. So as surgeons, we had the stereotactic tool that has advanced, and we can hit any point in the brain safely. Now, in the last 15, 20 years, since 1995, these are your tools that you have as an epilepsy surgeon today. You have gamma knife options, you have RCT data showing the results of craniotomy, you have vagus nerve, you have responsive neurostimulation, you have deep brain stimulation, you have laser ablation. So in the span of 1995 to 2011, 16 years, 6 surgical tools to treat epilepsy. So you're going to have a lot of people now considering different options rather than being on their 6th, 7th, 8th, 9th, 10th epilepsy drugs and not being cured. Because a lot of these therapies are transformative in terms of what life can do, and these aren't commensurate with any risks of craniotomy that the public is aware of. The public is really aware of your risks of craniotomies with head injury, right? It's probably 50-60% of the neurosurgery business, at least in this country. So this is the first patient that we did in December 2011, and that's the incision for this operation, and he remains cured. This is the girl that we did yesterday, 4-year-old girl with a hypothalamic hamartoma. She would have had a bifrontal craniotomy with retraction of her frontal lobes to get into her hypothalamus, and that operation, can only be done safely, probably in the hands of 10 people in the entire world without neurological deficit. That's Sarah and myself doing the surgery, having a cup of chai when we knew that the probe was in the right spot, and that's what she looks like 1 hour after the lesion in a hypothalamic hamartoma, right? Awake and smiling and happy. That's the picture of my first hypothalamic hamartoma patient that I did in December 2014. So I hope that I've convinced you that there is this transformative technology available. I don't really think it's anything new. It's really built on the foundations that our fathers in neurosurgery have given to us for the last 50 years. You've seen that change, when it happens really slowly and then accelerates. So right now, we are on the acceleration curve of epilepsy surgery. Thank you. Great attention. Should we take any questions?
Ash, that's a really great lecture which you gave. And I think we are on the threshold of a new revolution for epilepsy surgery. I think just like intervention. So I think it's just a beginning. So are there any questions? Yeah, we now come for the reality.
Over here in the front. Yeah, not at all. The anterocoroidal artery just doesn't heat up. No matter how hard you try, you can't heat it up. And we'll put a temperature sensor right in the choroidal fissure. And we'll put a temperature sensor right in the junction between the medial uncus and the cistern. So any vessel in that area, you'll see the heating. And when we show the case and you watch the heating, and I'll point out which ones are those 2 sensors, watch those temperatures and they'll stay flat. So, yeah, now the question is, are you affecting the blood vessels and the perforators to the amygdala? So the front of the probe, we're just doing in the lateral amygdala. We're not pushing so much medial, yeah. And because of the trajectory, which is more a long axis trajectory, you can't really get medial. In the first case that I showed of the cortical dysplasia, if I aimed higher, I'd have to consider that different. Now, you can, if you wanted to use the laser probe, I showed you that you can do a 1 millimeter cutoff. So if you look back at this, the girl with the hypothalamic hamartoma, just to give you a sense, right? She has, the slide is off, but you know that there's millimeter anatomy when it comes to the optic tract, the fornix at that area, and you can cut off the heat exactly at that spot within a millimeter. So if you can, the real challenge is if you can identify the white matter tract. So in the future, and what we've also started doing is integrating tractography into our planning, right? Show the tractography tracts and know that you don't want to heat any tract. You can control the diameter to heat as much as you want. So I had, so this issue came back to us very recently, and I'll show you the case just very quickly, just to prove you. We had a girl with bilateral parietal heterotopia and temporal lobe seizures. And we did stereo EEG to determine which, oh, can we put the slide back up? We did a stereo EEG to decide which, was this a unilateral surgical resectable, knowing that it might not be, right? It might be bilateral focus. And her profession was sign language with parietal heterotopia. So how do you preserve her sensory so she doesn't lose her stereognosis? And how do you preserve her visual pathways? Because that's all pertinent for a stereo EEG approach, right? I mean, for ablation approach, right? Because, and that's all about tractography because the white matter looks like white matter. So we incorporated DTI into the surgical planning, and I'll show you how that, how can I go to the last slide? So this was the first case that has been done with tractography. I'm sorry, I didn't actually put it in there. Okay, I have it in another talk. But this was the first case that was done with tractography, and I can't even see my desktop now. It's a mess. So it was the first case we did with tractography, and because when I've done resection, the posterior cingulate or the precuneus, if you even get a little bit of the corpus and the posterior part of the corpus callosum, they have some kind of reading, writing, alexia type problem. And in her, I was exquisitely scared because the lesion was right up to the corpus. And I wanted to spare also the corpus fibers and any crossing fibers in it. And so we did the tractography and spared it 100% with the dysplasia. So that's the type of precision tool you have for your.
Is the heat dissipation circumferential always, or you can just limit it to 1 millimeter anteriorly and then spread it posteriorly?
So they have directional probes. So if you want to start sculpting lesions, there are actually directional probes that will only allow heat to go in one quadrant. And then you turn the probe to hit other quadrants. So this probe that we're demonstrating is just a single unilateral probe. Yeah, yeah. But the next generation is already getting to the, the differential probes. Yeah, exactly. The problem though is that the differential probes are 3.2 millimeters in diameter. So so it's not very good for the hippocampus, right? In a mesial temporal sclerosis, hippocampus width and diameters are going to be 3 to 5 millimeters. The whole probe is going to, it's not going to get on target, right? But if you're doing heterotopias and cortical dysplasias and you want to do sculpting, that's going to be the sculpting generation.
Ash, there's a question from Kathmandu. So they are saying, they're on live.
Yeah.
They're listening to the lecture. So they want to know, when you do it for cortical dysplasias or some other lesions, can you do a simultaneous biopsy and then do it, or you think?
So we've done simultaneous before you put the laser probe. It's a great question because many times the issue is that you don't know if this is a long-standing cortical dysplasia or perhaps this is a low-grade glioma, right? And a low-grade glioma is going to have long-term follow-up, and arguably you might even want to do open resection if you couldn't get the whole cavity ablated, right? So in that type of situations, we put a biopsy probe to the target. We take the biopsy, then take it out, and then put the laser probe. So it absolutely can be done, and it should be done.
In post-op scan, there has to be some sort of edema. I mean, some degree of edema must be there when you are ablating a lesion by heat.
Yeah.
Because similarly with gamma knife, that Rose trial was started and ultimately it was stopped because there were a lot of temporal edema and people were not happy with this. So in your follow-up scans, did you observe any edema following this?
Yeah, no, Dr. Sharma, it's a great thing. So the question is about post-operative edema, right? And the reason a lot of people around the world stopped doing gamma knife was because there were many cases of malignant edema, 2-3 cases of death, and many cases of visual loss requiring optic nerve fenestration for the postoperative edema. So we've routinely given patients 7 days of steroids after surgery because we see a lot of headaches and a lot of this non-localizing sensory type complaints. So symptomatically the patient's having edema.
But have you done any scans in first day, third
Right.
day, fifth
So
day?
we've done scans only immediately after surgery, and you don't see the edema there. And our next scan, unfortunately, is 6 months afterwards. So I have no observation.
Yeah, immediately edema will not be there. It would
No,
be at 5 days, 7 days, or even 15 days later. So if you are doing this number of cases, then why don't you do this study as well? If there is any
Yeah, no, you'd
associated
have to.
edema.
The hard part for us is going to be to get the MRI approved. It's an insurance system. Then you'll have to get the patient to come back and get the MRI. It should be done. When we can, we'll do it. It's miserably difficult to get the patients to come back for a follow-up.
And another question is that it's so effective, then why to restrict it to epilepsy only? Why not in tumors also?
Yeah. So you're 100% correct. There are many people now that are using this technology for tumors around the U.S. In our program, we actually have a very different tumor service and a very different functional neurosurgery service. So the only tumors that I ever get access to is DNETs or low-grade gliomas or cavernomas in the temporal lobe. Otherwise, my other partners take it. And we have many partners who are using this. The complexity with this in tumors is it's going to be ideal for little marble-shaped tumors that are deep, because you'll be able to do that. If you have a shape that's abnormal, multilobulated like a set of grapes, then this tool is not adequate. Because then Gamma Knife, if you can sculpt it, has a better option. But a single deep-seated tumor, you're going to have immediate results on that, right? Without the effect of transversing radiation. Because there is actually some risk of whole brain radiation and Gamma Knife radiation to the entire cortex, and this is not causing that risk at all, right? Because it's exactly focal.
Could lead to some bleeding in the tumor?
Hasn't happened. You're coagulating. You're coagulating right then and there, right? And most tumor bleeding. So the most interesting fear that we have not done a cavernomy yet, but when I discussed, Emory University in Georgia has done now 10 cavernomas. And their idea is that the bleeding, when it occurs, is low flow. And what do you do if you have some bleeding anyway? You start coagulating, which is exactly what you're doing. So unless you had a high flow blood that kept squirting, which you should never have because you should know where the blood vessels are before you put the probe in, right? So you should be able to plan around that. So many centers, the question is, can this be done in the awake patients? So many centers actually started by doing it in awake patients. And most because of there's a complexity of doing general anesthesia inside the MRI suite, right? And your anesthesia team is not going to be happy. I mean, first of all, the anesthesia teams are never happy, but they'll not be happy going to the MRI with you either. So that's a whole culture that has to be transformed. We started doing them all asleep. Really, we thought for the comfort of the patient, the first few cases, it takes time to get the technology coordinated, and you're very imaging heavy, right? You're actually doing real life thermography. So every time the patient moves, you have to recenter the magnet. I bet you'll increase your operative, you'll triple your inefficiency of awake surgery, but it can be done if you have a cooperative patient. Over there?
Whenever you're planning the safest path for your for electrode, do we have a software which suggests the safest path for you?
No, not yet. I'm aware of 4 groups in the world that are working on trajectory planning, but nothing is validated and nothing is published yet.
Okay.
Yeah. For one trajectory like this, any neurosurgeon who is just detail oriented and go through every slice, I mean, you're talking about 30 slices, right? So it doesn't take that much long, and you go back and forth. And the only thing I'll tell you when you do it, just have a partner double check it, because you actually burn out at some point looking at the same thing over and over again because you convince yourself that you're happy with it. And then at some point, the attitude is, chalo, dekhte kya hota hai, right? I mean, let me just see what happens. So that's why it's nice to have a double check. For a single trajectory, I don't think a software is going to make a big difference until the world has experience with 1,000 cases that can be fed to a computer. I think when you're doing stereo EEG, when I'm doing 16 electrodes, to plan 16 electrodes takes 5 hours of planning.
I evidence that. That's why I
Yeah.
was asking that.
Yeah.
Whether we figure a software which actually plans for you that these are the safest trajectories for particular points.
Now, if you know software engineers, we need them over here.
When you started doing these cases first,
Yeah.
was there any problem of getting approval and permission sort of thing?
No, not at all. The tool is, see, when you use a drill in the operating room, a new kerosene, do you get approval? It's not. It's a tool. When you did radio frequency for the first time, let's say you buy a different radio frequency probe, you don't require, yeah. It's a tool. It's FDA approved as a tool to do ablation. Used for tumors, cavernomas, epilepsy. I've done cingulotomies. People are looking at it now for thalamotomies, pallidotomies, right?
So how much one probe will produce ablation? How much tissue will be ablated by injecting just one probe?
So this is the first generation probe from Visualace. This can give you 1.6 centimeter in diameter. Yeah, normally. Now, there's ways you can effectively go up to 2 centimeters by reburning the same exact spot. So if you actually burn, let's say you burn, you wait for the tissue to cool off, there's no blood flow in that tissue now, right? So heat is going to dissipate even further. So we've discovered over the last year that if you reburn the same tissue, you can get 2 more millimeters, but not more than 2 centimeters of heat dissipation. Yeah.
Yeah, so maybe the next line of treatment for tumor is this only, just a twist drill hole and you ablate it with laser.
Yeah, I think so. Yeah. Back there? Yeah. 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 So I think the just to give you the philosophy difference, and there are many factors that go into philosophy. Okay, so the Cleveland Clinic is considered to be one of the top centers, like you guys over here, right? And they have chosen not to offer laser ablation to a selective amygdala hippocampiectomy candidate, because if you do volumetric analysis and if you look at the amygdala, hippocampus, and entorhinal cortex as 3 structures, we cannot remove the same volume with a laser ablation. So there's no doubt that there's a technical limitation to how much we can. And that 10 to 20% seizure freedom rate, they have made the decision as an institution, we're not going to sacrifice it. Despite the neuropsychological consequence, despite the non-craniotomy, despite the discharge the next day and return to work, they as an institution said, we're going to do the surgery in the same candidate, we're going to choose maximum seizure outcome. So that's the philosophy that comes into play. Yeah, no, 100% right, because now you're getting creative. The discussion is, can you actually get more burn by putting more electrodes in, and where's going to be the limit? So we don't see so many cortical dysplasias at our institution, but Miami Children's, their practice is pediatric heavy and congenital defects, and they are often doing 2 or 3 laser tracts. So 3 little twist drills. And the next question that has to be answered then is how much volume can you burn in the brain to result in how much edema that won't cause a problem, right? That has to be answered next. And we don't know the answer. So the cost of a laser ablation in the US is actually cheaper than a craniotomy. A craniotomy, yeah, the cost of the question is the cost of the procedure and the cost of the equipment. So this is a really funny question, because the cost of a fiber optic probe, now I don't want to say that it's pennies, but it's really, plastic is not very expensive, right? And the machine is where the cost is. But there becomes a question of what the business model is. And I can tell you that when we look at the disposable costs in the US for craniotomy versus this is about $5,000 cheaper in the US.
So which laser is it?
Visual Ace, which is now owned by Medtronic. They call it a near infrared laser. Infrared. So that's also suspect to a lot of, I'm hesitant to give you the cost because I know that you will not pay the same cost that I did. We were the third installation inside the US, and we probably got it for 1/3 the cost. So if you're a good businessman, you should be able to get it for a cheaper price. The problem is now that it's becoming very, very popular, right? Inside the US, there's about 100 installations over the course of 4 years now.
But is this laser technology different than your freehand laser probes and all that? Is it different than that?
It is different from that. So there's a few differences, right? So there's no gas producing. This is infrared laser, so it's light. And you saw 2 catheters that I showed you on the screen. The initial catheter that goes, and then someone that goes inside. So the inside is a fiber optic, which is the laser beam, and around it is actually irrigation system so that you don't get charred tissue. If you get charred tissue on the tip of the probe, the infrared won't spread, right? So there was a little, and when you were doing a YAG laser with your hand, you're constantly irrigating and removing charred tissue, right? So it was never a concern. So with this, through a stereotactic approach, there's a little modification that had to be done.
How much is the volume of hippocampus that is burned? Around 2 centimeters? How much?
Yeah, it's about, so the question was how much volume of hippocampus is burned. And we've actually we've burned anywhere from 50 to 70%, 50 to 70% of the hippocampus. So the entire ablation dosing, if you look at the time inside the magnet, is under 5 minutes for ablation dosing. Inside the MRI, you're in there for about an hour because you're always thinking and acquiring more images and trying to assess what you do. You do about 3 effective burns because you pull it back a centimeter at a time. Yeah. Yeah, that's right. And then you remove it in the MRI. When we remember, which we try to get the team to do always, we put the stitch in first, so then all you do is close the stitch. Yeah, in one stitch. So you give the gadolinium right inside the MRI, the patient's right there. So give them the gadolinium and you just get confirmation. But it's probably not even necessary. We're doing it, honestly, we're doing the gadolinium because of the academic interest in quantifying the burn, right? We were looking for an objective quantification. The gadolinium always lines up with the computer estimate, the orange versus the gadolinium. So I think most centers do gadolinium just to give you the sense of security. Probably not necessary.
Is it by a twist drill hole or?
Twist drill hole, yeah. So you have to have the right drill bit. Okay, shall we go? Okay, guys, thank you very much.
Hippocampectomy. Now here there is a word of caution. Everybody has to understand. Sometime back I heard a surgeon saying that you've done temporal lobectomies in surgeries. Please go ahead and do. There is nothing different. So this is a statement which I will not more than disagree than what has been told. I completely disagree with this. So temporal lobectomy for epilepsy is definitely not the same as any for a head injury. You need a very good learning curve. Because you are operating on patients who are fully well preserved. Your aim of surgery is not to make the patient come out conscious, alert and oriented. Your aim of surgery is to make the patient seizure free and with good neuropsychological outcome. So you're operating on a patient who is fully and completely well preserved, and you have to not only treat his seizures but also improve his neuropsychological outcome. Just a minute. So we have already discussed the cases, so I will not go. Now you would see that the incision which we have given currently is much more smaller than this. We prefer to give a very small incision. So it's in a way it's a functional surgery, it's a cosmetic surgery. So we should try to minimize our skin incisions to as less as possible. We should not nibble the temporal bone. There's absolutely, even though you read the traditional textbooks, they say that you have to make a reasonably big incision. You have to nibble the base of the temporal lobe, you have to remove the bone. I will not agree with this. You will get enough space even with very small incisions. Now I will skip about this, but we have to understand that even though 70% of epilepsies can be helped with temporal lobe surgeries, epilepsy itself is not a focal disease, it's a diffuse disease. So if you see this very good paper which was published in Cerebral Cortex, they measured the thickness of gray matter. And then they found, so the thinner the gray matter, the more purple it is. So they found that in many epilepsy patients, the gray matter of the entire cerebral cortex was thin. So that is why the initial pre-operative workup is very, very important. You have to really make a very, very rational and a very, very mature decision on what your surgical technique should be. Now we have had this discussion of selective versus traditional amygdalohypocampectomy. And even though there has been no class 1 evidence, but meta-analysis from world over shows that a traditional ATL has better outcomes than selective amygdalohypocampectomy. So what is amygdalohypocampectomy? Sorry, why is this going like that? Yeah. So amygdalohypocampectomy is a complex of structures which have to be removed. So this of course includes the hippocampus. Most important, it includes the hippocampus, amygdala and entorhinal cortex. But apart from that, should also include the parahippocampal gyrus, the anterior part of parahippocampal gyrus, the subiculum, the uncus, and also the lateral part of the lateral neocortex, which is the tip of the temporal lobe. So we used to do selective amygdalohypocampectomy. It definitely looks more selective. We had neuronavigation, so it would feel very nice to give us just a small linear incision and remove it. But we have found, and we have burnt our fingers, that its outcomes are not as good as traditional. And when we went back and reoperated these cases, we have biopsied the lateral temporal lobe, we found that most of these patients ended up showing type 3B cortical dysplasias, even though we were not able to publish it. So how do we do it? So the first, of course, is a craniotomy, as I have told you. We open up, and when we open up the dura, this is the kind of exposure we should have. So you should see just a bit of frontal lobe and then the temporal lobe. You don't have to nibble the bone to expose the anterior part of the temporal lobe. It's not required. If you start your temporal lobe disconnection here, you will be able to take it out from here. Electrocardiography is not mandatory, but if you have it, it will give you a very good learning curve, and it will also, it's a baseline recording, you will see how abnormal the recordings are. And if you do it post ECOG, definitely it gives you a sense of confidence. But per se for mesial temporal sclerosis, ECOG is not required. So once we remove the anterior temporal lobe, this is the kind of exposure we will get. And this is the type of incision which should be performed. Now when you do the initial anterior temporal lobectomy, it's very essential that we should not hit the ventricle at the same setting. If you go back and see Faulkner's reviews on anterior temporal, he was the first person who described en-bloc temporal lobe resections. These are extremely dangerous. You try to do en-bloc, you end up having a lot of morbidity. So it should always be two-staged. So in the stage 1, without hitting the ventricle, you just laterally across and remove it. Now the best way to trace the ventricle is, you see the Sylvian fissure, you come down the Sylvian fissure parallel to that and you will hit the ventricle. So always see the Sylvian fissure, strip off the superior temporal gyrus, come down laterally and you will come across the ventricle. So finding ventricles sometimes can be a challenge. You can keep on searching here and there. So you have to keep your anatomical orientation very properly. In fact, it's surprising sometimes how difficult it can become. So when you open the temporal horn, this is how it will look. The hippocampus is at the floor. This is the roof of the temporal horn. Now we used to do this earlier, but it's not required for more for research purposes, because this was part of a research funded grant, where we used to introduce a strip onto the hippocampus and then take out multiple sections from hippocampus and send it for separate molecular and cellular analysis, just to see whether there is any differential epileptogenicity on the hippocampus. But putting a strip on the surface of the hippocampus is a good idea. You will get very good recordings. Now these are the tips to find the temporal ventricle. The tip number 1 is the ventricle can be reached by making an incision right through the temporal stem, and that is how you can get there. So the ideal trajectory is illustrated by the solid line. So you have to understand that if you go too medially into the roof, you can actually go into internal capsule. So you have to be very careful not to go medially, because the internal capsule is just 20 millimeters above the roof of the temporal horn. And if you come too laterally, you can go into the in floor of the temporal lobe and you can miss out the temporal horn again. So the best way is to follow the medial part of the Sylvian fissure, and it goes down straight into the temporal horn. So you can go ahead and strip the superior temporal lobe, follow the pia, come down and then go right up to the ventricle. Now the other way is, when you are sucking, you find amygdala, which is a grey matter area. You can go just posterior to that. So if this is amygdala, which is a grey matter area, you go posterior to that, you will find the ventricle. Now once you have identified the hippocampus, you have to go medially and you have to identify the hippocampal fissure. So when you identify hippocampal fissure, you have to be very much aware of what are the vessels and veins which are present, which are encircling on the lateral part of the brainstem axis. So you have two vessels. So any residents, can you tell me what are the vessels which are deep to the pia? Anybody, any of the residents are here? Anybody? I think nobody wants to get up. So you have the basal vein of Rosenthal, which is important, it should not be touched. You have the posterior cerebral artery, and if you go more anteriorly, you will come across the anterior choroidal artery. And you have to understand that these vessels, this is the anterior, these vessels, they give tributaries and arteries which get into the hippocampal fissure. So it's very important not to cauterize this. That is step number 2. Because if you cauterize this, this heat sink can go proximally and can cause thrombosis in the larger vessels. So absolutely no use of cautery in the medial part. Now we have to disconnect the hippocampus in toto. So once again, can anybody tell me why the hippocampus has to be removed in toto? For every resident who scrubs up with me, I tell him this answer. But still I find that many people are confused about it. Anybody here? Any resident or any student? See, mesial temporal sclerosis is a cytoarchitectural diagnosis. If you just remove with a biopsy forceps and give bits of hippocampus, the histopathology will not be able to make out anything. They will give back a report stating hippocampal ischemia. So they will not be able to reach a diagnosis. You have to disconnect, you have to give the hippocampus in toto. This is the second most important step which we have to do once you reach the ventricle. So in order to disconnect, first you start with lateral disconnection, go up to the pia. Then you go to the anterior disconnection. You can go between the hippocampus as well as the amygdala. Then medial disconnection. Now here you have to understand that there is a double fold of pia through which the vessels they enter and supply the hippocampus. So this pial fold should be dissected out as laterally as possible. And if possible, try to avoid cauterizing these vessels. They have to be stripped off from the hippocampus. And then finally, you have this posterior disconnection. So once you do this, the entire hippocampus is removed in toto. So this is a line called as a CP line which has been given in the textbook, but practically I have not found it to be so useful. So this is how we identify the hippocampal sulcus, and then the entire surgery is subpial. So you should not open the pia, and you will be able to visualize the third cranial nerve as well as the vessels under the pia, and the entire surgery has to be pia, because if you let the blood get into the subarachnoid space, you can end up having some complications. The perforatus can go into spasm and you can have problems. So this is how the hippocampus is delivered in toto, and you can see a short video how it is delivered. So this is the medial part, this is the anterior part because this is the left hippocampus. So I use a number 4 dissector, dissect it till I go to the pia, and you can see you have to peel off the hippocampus from the pia, and as you are peeling off you will see a very nice plane developing between the hippocampus and the pia. So now you go to the medial part. Medial part, ideally you should strip it off from the vessels, but sometimes you may not get the plane. So you have to strip off carefully, and you have a double fold of pia because the hippocampal vessels are supplying from the medial to lateral part. So you can see this is the hippocampal vessel which is coming from the double fold of pia and getting into the hippocampus and supplying to it. So once you have done it, the whole hippocampus should be removed in toto. This is how it has to be removed. Otherwise, your pathologist will not be able to give a diagnosis. So once you have done that, then rest of the things you can go on sucking it out. Now the question is, what is the extent of hippocampus which should be removed? Does the extent of hippocampus have any ramifications upon the outcome? Now there has been this very nice study done by Weiser et al., who was a neurologist to Dr. Yasargil, and he studied Dr. Yasargil's cases for almost 10 to 15 years. He went on doing MRIs for them, and since Sweden you have an excellent follow-up. He tried to see who are the patients who have had good outcome. So if you see, this is amygdala, this is hippocampus anteriorly, and this goes up to here. So over here you find the collicular eminence or the brainstem. So the point where the hippocampus turns into the atrium around the brainstems at the level of the superior colliculus is the extent to which the hippocampus has to be removed. So removing hippocampus doesn't mean that you're just nibbling it. That is not the end of surgery. You have to trace hippocampus as far posteriorly as possible, and you have to go up to the superior colliculus. Only then your patient is going to have a good outcome. Otherwise, after 6 months, 7 months, he is going to come back with seizures. So after this, rest of the structures like uncus and entorhinal cortex can be removed with suction as well as dissector as shown here. You don't have to be so much obsessed that you have to remove it in toto. So normally what I do is I take a dissector, I just keep on peeling it off from the arachnoid and keep on using suction till I reach the pia. You can see that. So I also use Penfield number, the scoop of Penfield 1 dissector just to scoop out the brain matter. So we are now going, this is superior. Now it's very important. Now there are 3 important no-nos. I mean, these are some things you should never do. Otherwise you will end up having complications. Number 1, do not cauterize over the choroid plexus. You see the choroid plexus, you put cautery. If the anterior choroidal is not dominant, then you're lucky. But if the anterior choroidal or there is some branches of PCA coming, the heat goes into the PCA, you can end up having, the patient will never wake up from surgery. That's very, very important. Number 2, you should not go into the roof of the temporal horn, because just 20 millimeters above that is the internal capsule. So you go on sucking the roof of the temporal horn, you are going to end up in problems. And number 3, keep the pia intact on the medial part. If you see that the pia is breaching, sometimes it may be even good enough to leave a bit of cortex there. Because once you breach the pia, the blood goes there and you can end up having problems. So this is how it is to be removed. So people say that you can use CUSA, but I don't use CUSA. I don't find it so convenient. I just find suction and pen-filled dissector good enough, very good in fact. So these are the structures which are there mesially: choroid plexus, basal vein of Rosenthal, posterior cerebral artery, and anterior choroid artery in the anterior part. So if you see the hippocampus, this is the hippocampus head, body, tail. That is where it's going around the atrium. So till this point you have to remove, which is the level, which is the posterior part of the brainstem. That's the third nerve, that's the PCA. So just to show that end of surgery, this is how it should look like. So this is anterior, this is posterior, this is superior, you're looking at from above downwards, this is lateral. So you can see the pia right from the anterior part, so you can see the third nerve under the pia, curving around like this and going till the posterior part of the brainstem. So the whole curve of hippocampus till it reaches the atrium has to be removed. Once again, do not go beyond the roof of the temporal horn because it's very close to the internal capsule. So this is how it looks at the end of surgery. You have to achieve meticulous hemostasis because if there is blood there, we have seen a few cases, it may be very, very uncommon, but we have seen incidences of vasospasm occurring. Just to summarize, this is how it looks. So anterior temporal lobectomy, you find the choroid plexus, you find the hippocampus. So this is how the hippocampus has to be dissected anteriorly, medially, laterally, as well as posteriorly. Subpial dissection has to be done. And at the end, entorhinal cortex, uncus, and all the joining structures have to be taken out. So that is briefly about how to perform the surgical technique. And if there are any questions, I will answer. Otherwise, I will go to the OT because they are ready to open the dura.
While doing this cortical dissection, do you take the whole of the superior temporal gyrus along the subfile?
I take the anterior part of the superior temporal gyrus. Because posterior part of superior temporal gyrus, even in non-dominant lobe, has got some functions. So the anterior most part of the superior temporal gyrus, if you strip from the pia, you go on stripping it, and that directly leads you to the temporal horn.
Anterior means how many centimeters?
Just the anterior most part of your craniotomy, that's good enough.
But then temporal horn will not be as anterior as that.
See, I understand what you say, but when you do a craniotomy, you don't nibble the bone. The temporal horn more or less will be at that point. Because the anterior temporal lobe is still much more anteriorly. So you don't have to nibble the bone. So you're there at that point, you start stripping the superior temporal lobe, you go down straight to the temporal horn. We are not visualizing the tip of the temporal lobe. Tip of the temporal lobe is much more anterior. So we are actually working at an angle without removing any bone. Amygdala is a grey matter which is present in front of the temporal horn. So this can be sucked out. So once you disconnect it from the hippocampus, the entire grey matter, which is amygdala and its connections to the anterior temporal lobe, can be sucked out anteriorly with a suction. So once the entire pia in front of the temporal horn is exposed, you know that you have removed it adequately.
Do you use this like from the tip of the temporal horn anteriorly to the bifurcation of MC?
Yeah, that is called as a CPS. Somehow I have not found it very useful. Even though traditionally in books it has been described, I have found these parameters to be very, very practically useful.